So, hi all, a very good evening. Uh, Welcome to the revision series for Part 1 University exams. And today, as you are all aware of, today we will be discussing the subject perio. Okay, so sorry for the interruption. Yeah, so today we will be discussing the subject perio. And so, as you are aware of, when we talk in terms of perio, I think uh, subject wise, uh, Perio is a subject which is easy to read and understand. But what makes it difficult is that its vastness. Perio ഒരു ഭയങ്കര vast ആയിട്ടുള്ള subject ആണ്. That, it will take so much of time to cover the entire subject. And എനിക്ക് തോന്നുന്നു, like, that is what restricts students from, even starting to read it. And prepare for the exam. That is what makes it difficult to prepare. We talk in terms of exam point of view also. So here in this session, what I thought was like, and especially in this present situation where you have hardly like maybe 2.5 weeks ahead for your university exam to begin, and you have all the subjects to revise, not only perio. I think something which we can do to help you all crack the exam and score good marks for the university exam is to identify the niche topics or high yield topics, okay, from which frequently questions would be asked, okay, for the university exam. That is uh, the that is the easiest way by which, not only in the current scenario, it is a like evergreen method to score good marks for your university exams. Okay. So like you need to identify those high yield topics. Okay. From where questions would be frequently asked from. And for sure, about 85 percentage of times questions will be like repeatedly asked only from these areas. And of course, maybe one or two questions will be there which would come out of the blue, like from totally unexpected areas. Okay. So in this session, I'll be discussing the frequently asked repeated questions, and also will be giving an idea about, those unexpected questions that can come for the exam. So you may take a note of all those questions. Okay. And besides that, I would also be sharing some tips, or maybe, I'll give you an idea on how to approach your exams altogether, like how to write an essay, how to write a short note, how to present a brief note, like that, so that it will help you save a lot of time during the time you write the exam. Okay. So, and as I've already informed you in the group, and as per the request from the participants, like most of the questions discussing today would be from the surgical part of perio, because I think as an in the undergraduate level, that is where students find it very difficult when they read, because uh, usually we are not that exposed to surgical procedures and also while reading it, and certain things, until and unless we do it, things when it doesn't get into our mind. So I'll try to make those portions as simple as possible. And if you have any doubt while I explain it, you can save it for that 15-minute last session for discussion. Okay. And let me know. So coming on to how to approach your exams altogether. It is not only with perio, but for any subject, I think this would benefit you, because, this is what I have done for my university exams. And like I could score distinction or above distinction marks for all the subjects. So I think this has worked pretty well for my exam. So I think would benefit you also. So with regard to for your exam, its pattern is like 70 marks it will be out of 70 marks. So you will be having two essay questions and then four short notes and 10 brief notes, right? And the mark distribution also it's being written in the slide. Yeah, essay will be out of 10, short notes will be for 5 marks, brief notes will be for 3 marks each. So I would say first and foremost thing which you have to do is divide your time, the whole time you have for the exam for each of these sections, because otherwise you will end up in having no time to attend some of the questions. And if it is those questions are what you know, that is the worst thing that can happen to you. So that shouldn't happen. Always attend all the questions, even if you know or don't know, you should attend all the questions. That is the first and primary thing that has to be there in your mind. Never think of leaving any question, and divide the time for each section. Like, for example, put like 1 hour each for each of these sessions, so that at least by 1.5 hours you will complete essay part. Okay, so divide like you will dedicate 1 hour for essay section, 1 hour for short notes, and 1 hour for brief notes. Okay, fine. And then how to write each of this, like how to write essays, how to write short note, and how to write brief note. I'll give you a sample question and I'll describe it step by step. Meanwhile, something which would benefit you is at least make sure that for an essay of 10 marks, make sure that at least you should write 3.5 pages, excluding the content part for an essay. 3.5 pages. And for short notes, 2 to 2.5. When I say this pages, I don't mean sides. Okay. I mean a page with two sides. Okay. So 3 full pages or 3.5 pages maximum for an essay. And short notes, maybe 2.5 pages. And for brief notes, maybe 1 to 1.5 page. I think that would sufficiently, you know, give an impression like, or will help you put all what you know for the question, that particular question. And don't override too much and finally end up in no time for the questions. So that is the page wise distribution. Now, first, I'll give you a sample uh, on how to, because in this session, I'll be discussing mostly essay questions. Because while covering the essays, most of the short notes in the section will also be covered. So I thought that is an easy way to cover maximum portion from the surgical part, especially. And to help you understand how to put across an answer, I have selected two simple but very commonly asked questions. For example, like this question. This is a very frequently asked question from acute gingival infection, ANUG. Okay, acute necrotizing ulcerative gingivitis. This might be very familiar for all of you, but then it is a very important and very frequently asked question from the university exam point of view. And actually, from acute gingival infection, all the portions are very important short notes or brief notes, whether it is abscesses, gingival abscess, periodontal abscess, pericoronal abscess, primary herpetic gingivostomatitis, all of this are being repeatedly asked. So that chapter altogether is very important from the exam point of view. And you need not expect an essay from it. It will be mostly short notes or brief notes. But if this question is being asked as a short note, ANUG, what I meant was for an essay, it is mandatory that you will have to write a contents of what you are going to present in that essay. Okay, content and all portion is must written on. Other you will have to write introduction, definition, like that. You should list out all the titles in the front page of that question. Uh, for a short note, if you ask me, even though you need not list it out in the as a content, the title should be highlighted. Okay, the titles under which you are putting across the answer should be highlighted. For example, in this ANUG, if a question like that is asked, okay, give an introduction. Okay, what is ANUG? Isn't this is an example for an opportunistic infection, right? That is, what is opportunistic infection? A disease that occurs when the overall immunity of the patient comes down. Okay, so this is an example for an opportunistic infection. commonly seen in immunocompromised patients. And for example, in HIV patients, smokers, stress, patients with stress and other conditions. Okay, these are the conditions which predispose to ANUG. So that will form your introduction. Then the causative agents. So that title you have to give and highlight it and then rewrite it. Okay. What are the organisms that are the primary causative agents? Borrelia vincenti and Fusobacterium are the major organisms which cause ANUG. And these organisms can be identified by dark field microscopy. Okay. Then the other terminologies, which includes Vincent stomatitis, trench mouth, fetid or putrid stomatitis. Then location, where it is commonly seen. Okay, it is seen, you all know the presentation, the clinical presentation of ANUG is like punched out crater-like depressions, no? In the marginal crest of the gingiva and the interdental papilla. So you will have to write the location as interdental papilla. It begins in the interdental papilla and then the gingival crest. And if it is left untreated, it further advances to other parts of the gingiva as well as the oral cavity. That is the presentation or the location. So what I mean is give always titles for short notes and highlight those titles. Okay. And coming on to the clinical feature, it gives a punched out crater-like depression. You should then, which we have already told, and often covered by a pseudo membrane, which is very easily, which can be very easily pulled off painlessly. Okay, that is the classic clinical feature for nerve, and it bleeds spontaneously too. And other features include metallic taste, fetid odor, lymphadenopathy, then increased salivation, fever, malaise, all these things. And then based on the degree of extension, okay, it is being classified into different stages. And it always, when you give off classifications or definitions, you will, if there is a person who has proposed that, always write it along with the title. Okay, so that it will be catchy, so that examiner will get an idea you have thoroughly, studied the content. Okay, so it is according to, it is Horning and Cohen who gave off the stages for now. So you will have to, and wherever possible, include diagrams. Wherever possible, draw tables and flowcharts. And sometimes certain, pathogenesis and all such things, which, which are very elaborated actually if you keep on writing. So whenever you study, make flowcharts and study for that, because it will help you save a lot of time. Okay. So here, when the stages are written, draw it in a table. Okay, and also make sure that, okay, stage 1, it starts with the necrosis of interdental papilla. Stage 2, necrosis of entire papilla. Stage 3, it is extending to the gingival margin. And similarly, you have 7 stages. Okay, I hope you all know that. And also, on to the side, you can write the progression, how it progresses from necrotizing ulcerated gingivitis to periodontitis, and then stomatitis, and finally noma, that is perforation of the cheek. So this entire table would give the idea. Okay, it gives in a lot of information, right? So, and it is very good presentation wise also. So it will fetch you a lot of marks. And finally, with relation to ANUG, you will have to write the histopathologically or microscopically when viewed. Okay. It shows 4 zones. Okay. What are the 4 zones and who gave off those zones? It is Lister-Gardin who gave off those zones. That is a section of gingiva which is, prone to this ANUG. When they are taken and viewed under microscope, it shows 4 zones. Okay, which includes the first zone, the most superficial zone, as the bacterial zone. And then beneath the bacterial zone, you will have the neutrophil zone, and beneath which you have the necrotic zone, and the most inside, in the depth, you have the spirochetal zone. And because those organisms, spirochetes, they have a high, ability regarding the depth of penetration. That is why they are found in the deepest part. And the most superficial is the bacterial zone with other bacteria and some of the spirochetes. Okay. So this zones also you should be thorough with, and you should give it in the answer. And finally, the treatment of NUG. First and foremost treatment is what? Oral prophylaxis. And then a debridement with hydrogen peroxide. You can also give off the dilution, okay, equal amount of water. And for 1 week, patient will be asked to rinse with this hydrogen peroxide mouth rinse. And then antibiotic, patient can also be put on antibiotic if there is systemic involvement. And then recall the patient after 1 week and do gingivoplasty, that is just reshaping of the gingiva if it is necessary. And any further extensive periodontal therapy or extractions, okay, should only be done 4 weeks after the initial therapy, that is once the symptoms subside. Okay. So that is how you put across a short knot. Okay. So I told you it will cover around 2 to 2.5 pages. Okay, when you write it. And when an essay is asked, okay, first I'll tell you a very simple, basic question, uh, how to put it across the question for you to understand. And then we will move on to the surgical part. Okay. So this PDL is a question, very important. See, you can see it has been asked even recently, and even in 2006, when I referred question papers from 2016 to 24, like it has been asked maybe about 3 or 4 times, and even recently, and irrespective of the time, okay, it has been asked. So it is always important. Okay, so that is the questions being asked was discuss in detail the structure and function of PDL. And the other question was explain in detail about the principal fibers and functions of PDL. Okay. And the short notes which are frequently asked are like, so that's why I told when we cover this essay questions, no, we'll be able to write the short notes also. That is functions of PDL, cells of PDL, principal fibers of PDL. These are the short notes which are frequently asked. So we'll cover it in the essay format so that you will get enough and more idea for the short note also. So when an essay is written, first and foremost thing which I have told you is that you should definitely write contents in the first page. Even if it is a question that you don't know, you don't know anything about, okay, so you will start writing, no? So leave some space for the contents to be written later so that you can fill in those spaces after you have completed writing all the answers. Okay, so contents is a must for essay. So for PDL, if this question, discuss in detail structure and function of PDL, that question has come, I would write the contents as always begin with introduction, definition if it is there, then the terminologies if it is there. It would come for everything. If any question related to PDL, it is the same, the content. Okay, that is introduction, definition, other terminologies. These will come in the introductory part. Okay, then regarding structure and function was asked, so shape and extension and the radiographic feature, structural components, principal fibers, because actually principal fibers are something which comes in the structural component, but these form the major bulk of the periodontal ligament. So it's that important. So we have to highlight it in the content. Okay. For the examiner to know that you have written about this. And then the functions, blood supply, venous and lymphatic drainage, nervous innervation, and conclusion. So then everything about PDL is actually included in this. Because when the structure and function is asked, even blood supply, the venous and lymphatic drainage, nervous system which innervates, it all comes in the structure. So you cannot skip it. So you can give any introduction. I have given like the introduction to periodontium. That is periodontium. It derives from the Greek words peri means around and odontos means tooth. So meaning structures that are present around the tooth. And the normal periodontium comprises of 4 tissues, which is inclusive of the periodontal ligament. Okay. And these 4 tissues, they function together as one unit to provide support to the teeth. Okay, that serves the introductory part. Now coming on to the definition of PDL. So this is defined as a complex vascular and highly cellular connective tissue that surrounds the tooth root and connects it to the inner wall of the alveolar bone. So that means, this definition you have to by heart. This is from Karanza. Always when you take it from a standard book or if an author has given this definition, you caught it in the bracket. Okay. So this is defined as a complex. So from the definition, it is very clear. PDL has got high vascularity, blood vessels and things, and also highly cellular connective tissue. So it's composed of numerous cells also, and it surrounds the tooth root. Okay. And the synonyms means the other names pertaining to PDL. You need not make sure that you write every name. You just write 3 or 4. That is sufficient. Okay. Desmodont, gomphosis, pericementum, periodontal membrane, like that. And then the extension and shape. Okay. So what is the extension? PDL, it continues in the coronal portion with the lamina propria of the gingiva. Lamina propria means the connective tissue of the gingiva, which is demarcated by the alveolar crest fibers. Okay. And in the root, the apical portion, it is continuous with the dental pulp. Okay. And then shape-wise, it has a hourglass appearance. Okay. That means it has a dip, it has a narrowingness in the almost in the middle. It is actually speaking, it is at the apex of rotation, not in the middle, at the junction of apical third and the middle third. Okay, for single rooted teeth. So it has an hourglass appearance, narrowest in the region of axis of rotation. And also you will have to highlight the width. Width, it ranges from 0.15 to 0.38 mm. Okay. And the scenarios where you get a narrow PDL and the scenarios where you get a wide PDL, that also you will have to write along with us. That is at the fulcrum of axis of rotation, we have already told, and in teeth which are hypofunction, okay, which are not in that function, okay, then there will be narrowing. And also in case where the tooth has drifted mesially because it is adjacent to an edentulous space, and when it drifts mesially, then there will be narrowing of the PDL on the mesial surface of the root. And just opposite scenarios. Okay, that means in hyperfunction, where like examples are TFO, that is trauma from occlusion, there will be widening of the PDL. And also in certain bone diseases like scleroderma, osteosarcoma, hyperparathyroidism and all that, there will be widening of the PDL. Okay, that also you can call it. So these are the scenarios where there can be a change in the shape. Okay. And coming on to the radiographic feature, the PDL, it appears as a very thin radiolucent line running parallel to the root surface, right? And it is bounded by a very dense radio-opaque line, which is the lamina dura. What is in bracket you can write what is lamina dura, okay, because it represents the fibers that gets embedded within the bone, okay, the fibers, periodontal ligament fibers that get embedded within the bone, that gives off this radio density, okay. And then coming on to the structural components, it has majorly cellular elements, that is numerous cells, and extracellular component, that is outside the cells you have certain other, matrix and fibers. Okay. But there you will have to write periodontal fibers also. Actually, this is an extracellular component, but you will have to highlight it because they form the, principal component in the structure of the PDL. And then you have when the structural components is asked, now I have just enlisted it, but if you give a flowchart like this, it will soon, make the examiner know that, okay, so you know about the whole structural components. Okay. When it comes to the cells, you have all the cells in the PDL, that is synthetic cells, resorptive cells, progenitor cells, defense cells, all cells are there. Okay. Means synthetic means what? Forming cells. You have osteoblasts, bone forming cells, cementum forming cells, and fiber forming cells, fibroblasts. Every cells are there in PDL. Similarly, you have resorptive, all resorptive cells also, osteoclast, cementoclast, fibroblast. Fibroblast is again a resorptive cell because fibroblasts, they have dual function. They synthesize as well as they also help in the degradation or resorption. So they can be written in both the cases. And beside these cells, they have the progenitor cells. Progenitor cells are precursor cells, which gives, they differentiate and forms these primary cells. Okay. Then you have the immune cells, which are otherwise called as the defense cells, which includes neutrophils, monocytes, macrophages, mast cells, all that. And then, of course, the epithelial rest of malaces also is seen, which are nothing but remnants of Hertwig's epithelial root sheath. Okay. which are found distributed throughout the PDL closer to the cementum. Okay, so along with this flowchart, you can maybe on the side, you can add another column just describing each of this. Okay, and coming on to the extracellular substance, you have the major part formed by the fibers, which includes the principal fibers as well as other set of some fibers, like some indifferent fiber plexus and immature elastin fibers, and also the ground substance, which are proteoglycans and glycoproteins. So now coming on to the major bulk of the PDL, that is the periodontal ligament fibers. Okay, which includes what all things? Principal fibers. Sharpie's fibers is again the principal fibers, which that portion of the principal fibers which are embedded in the cementum and the alveolar bone. So that you can write in a bracket. And then the immature fibers and indifferent fiber plexus. And then you will have to write about each of these more with more stress for the principal fiber groups. Okay, the principal fiber groups, they are the most important elements of the periodontal ligament, which is made of type 1 collagen. And they are arranged in bundles. And, these fibers are remodeled by the periodontal ligament cells according to the needs, physiological needs, and in response to the stimuli, an introduction part for the principal fibers. Then you can draw a picture, okay, for showing all the six principal fiber groups. There are 6 principal fiber groups. You can draw a picture showing the 6 principal fiber groups. And then you can enlist each of these fibers and then maybe write 1 or 2 sentences which are very important. Maybe the course, okay, how they run, that can be written. And also the function can be mentioned. Each of these fibers, how do they help in, anchoring the tooth in the socket. Okay, so when it comes to the transeptal fibers, at least 2 or 3 sentences can be written, okay, for each of these fibers. So, transeptal fibers, what are they? They are actually fiber groups which run interdentally between 2 teeth. Number 5, no, that is what is the transeptal fiber group. So they actually run above the alveolar crest. They don't have any attachment with the bone. Okay. So between the 2 teeth, they will run. And they are also, classified under gingival fibers because they don't have a bone attachment. Okay. So they are also classified in the gingival group. And they are otherwise called as interdental ligament also. And then you have the alveolar crest fibers. Okay. The course, when you say no, it is always from the cementum to the alveolar bone. That is how how they would run. Okay. So the alveolar crest fibers, they run from the cementum of the root to the alveolar crest in the apical direction. Okay. So, and always remember the function or of the PDL fibers, no, it will be just opposite to the direction of their course. Okay. ഏത് ഡയറക്ഷനിലാണോ ഫൈബേഴ്സ് റൺ ചെയ്യുന്നത് അതിന്റെ ഓപ്പോസിറ്റ് ഡയറക്ഷനിലുള്ള ഫോഴ്സസിനെയാണ് അത് റെസിസ്റ്റ് ചെയ്യുന്നത്. ഓക്കെ, ദാറ്റ് മീൻസ് alveolar crest fibers, I told you, they run in an apical direction from the cementum to the alveolar bone, right? So what do? They prevent the tooth extrusion, opposite direction. Okay, the fibers, they run apically, so they prevent the extrusion force. And then horizontal fibers, they run laterally, okay, at right angles between the tooth and the bone. Okay, so they prevent the lateral forces. And the oblique fibers, they form the major bulk of the periodontal ligament fibers. Okay, the periodontal principal fibers form the major bulk of the, the structural component, and among which it is the oblique fibers which forms the major bulk of the principal fibers of the PDL. So they run from the cementum to the alveolar bone in a coronal direction. So what do they do? What is their function? So since they run in the coronal direction, they resist the vertical masticatory forces or intrusive forces. Okay, and they form the highest in number. That also you can add as a point. And then coming on to the next one is the apical fibers, which, as the name itself suggests, is fan out in the apex of the root, and this is absent in incompletely formed roots. And interradicular fibers, they fan out here in the between the 2 roots in the furcation area. So with that, I hope that is clear. And then you add a knot on Sharpie's fibers, which we have already told you. They are what? Okay. They are the ones, the principal fibers, which are embedded into cementum and the alveolar bone. And this I've written the function in a separate table. That way also you can present it for the exam. And then coming on to the next group of fibers, which are indifferent fiber plexus, which are also collagen fibers, but small collagen fibers which run in all directions. So that for further reinforcement of the tooth in the socket. And then finally, the immature fiber groups, you just write the name oxytocin and iluanin, and they run parallel to the root surface and they thought to regulate the vascular flow. Okay. And now we have seen the fiber part, no? This is the cellular part. If you have already written these points in the flowchart, then you need not write again in the exam. But if you have not written, if you choose to write it separately, then you will have to write one sentence under each of these cells. Okay. And with more importance giving to fibroblasts, because they are the most common cells in the period. And so what is their function? So you can just write as these are the most common cells in the period, which are ovoid and elongated, and they are oriented along the principal fibers of the periodontal ligament. And the function is they are responsible for the formation of collagen, as well as they phagocytose old collagen fibers. Okay. And so their function is regulation of the collagen and the fibers. Okay, they regulate this turnover, collagen turnover. That is their function. And now finally coming on to the ground substances, okay, which fills up the space between these fibers and the cells, which you have the glycosaminoglycans and proteoglycans, the main components. Now finally coming on to the function, okay. So uh, regarding the function, you have got 5 major functions. That is physical function, which includes, they anchor the tooth within the socket, right? And they also act as a shock absorption by resisting the impact of the occlusal forces. They also help in transmitting the occlusal forces to the alveolar bone and also protects the adjacent vessels and nerves from injury from the mechanical forces. So this much is included in the physical function. And then you have formative and remodeling function, which we have already seen, right? It has got the fibroblast, which has a property of synthesis as well as degradation. So they help in collagen turnover. And then they have the nutritional function and sensory function. So that is, they supplies nutrients to bone, cementum, and gingiva, all the other tissues by numerous blood, because they are highly vascular. Okay. So they have numerous blood vessels and, arteriovenous anastomosis and lymphatic drainage all accompanied with it. So they help in supplying nutrition and also for the lymphatic drainage. And regarding the sensory innervation, they have got sensory nerves that supply the periodontium, which mainly arises from the maxillary and mandibular division of trigeminal nerve. Okay. So, and so they give this the feeling of proprioception because of the nerves innervation. And finally, you can add a note on the various theories. Okay, if it is not the theories, that just one sentence is needed. Okay, that is, you just write the theories, uh, that explains how the PDL supports the tooth in the socket, right? So that is related to function. So you write the theories, just the names, you highlight it, and then 1 or 2 sentences underneath it. That is, for example, if it is tensional theory, it states that it is the the principal fibers of the PDL that plays a major role in supporting the tooth. How do they act? When the force is transmitted, the PDL fibers, they straighten, and when they straighten, they cause the elastic deformation of the socket, and once the force is withdrawn, they comes back to the normal. That is what is tensional theories. Viscoelastic theory states that there is some fluid between these fibers, which actually is responsible for the mechanism of tooth support. That is, when the force is transmitted, this fluid, it passes into the alveolar marrow spaces. And then, so once the fluid is gone from that PDL space, it stiffens. And so it gives that shock absorption like property. Then finally, the most accepted and the most followed theory nowadays is that the PDL behaves like a thixotropic gel. Okay, that is it shows a property when shaken, it becomes a fluid and then becomes semi-solid again. Okay, a rheologic behavior. So you have to write. And then blood supply. We have already seen the nerve supply and lymphatic drainage and all. Now, finally, the blood supply. In the blood supply, it majorly gets blood from the apical vessels here. And also this alveolar, from the alveolar bone, various anastom penetrating vessels are there. And also anastomosing vessels from the gingiva. And you can maybe draw this image also. Okay. So the three sources from which blood supply is gained. And finally, you have as a conclusion, you can write the age changes in association with PDL, the cellular activity and number, it decreases with aging. And also, the activity of the PDL tissue, generally it decreases. And clinical consideration, when we speak about, as you all know, you know, uh, the inflammation, as a result of extension of inflammation from gingiva, it extends to the PDL and then to the bone, causing distraction of attachment, epithelial attachment, as well as bone loss, which is then difficult to be regenerated. Okay. And in cases of traumas, like acute trauma, in case of like trauma from occlusion or maybe an accidental blow and all that, this PDL can undergo hemorrhage and necrosis. And radiographically, you can see widening of the PDL. And also similarly in orthodontic tooth movement. Okay. What happens is that when a force is exerted, the PDL fibers, they stretch. And that side is called as a tension side. And the area where it stretches, okay, the stretchy, the PDL fibers, they dilate and they stretch, no, and the blood vessels all dilate. Okay. That area is the area where bone deposition takes place. But opposite to this side, where the force is exerted, opposite there is a side called as a pressure side, where there will be a compression of the fibers and compression of the vessels. And that is the area where actually resorption takes place. And the force, if it is not within the limits, it can cause undermining bone resorption and, hyalinization and all that. Okay, so with that, we'll conclude about the PDL. That is, the cells, in the conclusion, I've written as the cells of the PDL are pluripotent, means they have the ability to transform into any cells that is needed at the time. So they helps in regeneration of all components of periodontium lost in the periodontal disease. That is my conclusion part. Okay. So I hope you got an idea on how it is to be put across, how an answer is to be put across when something is asked for an essay, right? Like you will have to write on everything, but what is just important and majorly on the second part of the question. Okay. And content should be a must in while you write an essay. And now moving on to the other important essay questions. And we'll start with pocket because today we'll be seeing mostly about the surgical aspect. So we'll start with the pocket. So pocket is another area which is very important and you can expect questions this year. So there was a question in the previous year paper, define and classify periodontal pocket and write in detail the microtopography of gingival wall of the pocket. So here again, uh, so if a brief note is asked, you need not write so much. You can just stick on to what is being asked. You just write an introduction, maybe a definition if it is there for that relevant topic, and then directly move on with the classification. Okay. But if otherwise for an essay, you don't just stick to what is just asked, but relevant topics also should be covered in your answer. For example, if define and classify periodontal pocket, write in detail about microtopography of gingival wall of the pocket. So that you will have to cover, you have to give first introduction, definition of the pocket, classification of the pocket. Then pockets as healing lesion, because it is one of the topic which comes under classification, but still as this is important for the examiner to know that you have written on this, that I have included it in the contents. And then how to diagnose the pocket, then the pathogenesis of pocket, then the histopathological features under which the microtopography of gingival wall would come. Then finally, the pocket contents conclusion, where I have written about the management of the pocket. Okay. So here, in introduction, you can write anything like, but something relevant. Okay. So this pocket is one of the most important clinical features of periodontal disease, isn't it? And the cause for this is mainly the extension of inflammation leading to pathologic deepening of gingival sulcus. Okay, how this pocket is formed? It is actually the deep, pathologically deepened sulcus, right? So this occurs by either by the coronal movement of the marginal gingiva, either it is just by the coronal movement or by the apical displacement of the gingival attachment, or a combination of both. Okay. So the mechanisms by which a pocket is formed or sulcus get deepens. Okay, that is what we are discussing about. A normal sulcus, it is probing depth is 2 to 3 millimeter. No, so anything above which it is considered to be a pocket. So which again favors the anaerobic organisms to thrive and destruction of the periodontium. So we consider that as a pocket. So how do we get this deepened sulcus? Either the attachment will be there itself, but the gingiva would coronally migrate, or otherwise, as in the second picture, the attachment itself might have, lost, and then it recedes further down apically along the tooth surface or the root surface, or a combination of both can also happen. Then coming on to the definition of what is a pocket, it is a pathologically deepened sulcus. And then you have gingival pocket or pseudo pocket. Okay, where it is pathologically deepened sulcus due to coronal migration of the marginal gingiva. Okay, so here the attachment will be remain the same, but the coronal gingiva itself will it moves coronally so that pocket depth increases. And then periodontal pocket is actually defined as, it is the true pocket. Okay, so that is defined as the pathologically deepened gingival sulcus due to the apical migration of the junctional epithelium. Okay, so that is what is a true pocket is. So in definition, you can write what is pocket, then true pocket, and false pocket, or maybe gingival pocket or periodontal pocket. Okay. Then classification, when it comes to the classification, according to, there are about six ways by which you can classify pockets. Okay, so how, when you write the exam, like you will have to number each of this criteria on the basis of which we have classified, and under each of the pocket, you need to write what is what. Okay, how it is different from the other. Okay, so that is, first one is according to the morphology, which we have already discussed, but you need to rewrite in the classification. Okay, that is gingival pocket or relative pocket or false pocket. So what is that? We have already described it. Then periodontal pocket, absolute, which is otherwise the true pocket or absolute pocket, then a combined pocket. Always make sure for these questions like this, it is very easy to draw diagrams. So wherever possible, draw diagrams. Okay. Then according to the relationship between the base of the pocket and the alveolar bone, okay, then you can classify the pockets, okay, into suprabony pockets and infrabony pockets. What is suprabony pocket? Okay, so here, see, here there is a pathologic deepening of the sulcus by the, this is a true periodontal pocket, okay, where, there is apical shift in the epithelial attachment. And the base of the pocket, it is above the crest of the alveolar bone here. So it is called a suprabony pocket, okay, or supracrestal or supraalveolar pocket. Whereas in the second picture, you can see the base of the pocket is below the crest of alveolar bone. So which is the infrabony pocket. And about the gingival and periodontal pocket, you can write in, I've told you, you have to write 1 or 2 sentences underneath, or you can give off the definition if you have. And also you can write in the gingival pocket, there is no destruction of the underlying periodontal tissues. Okay. It is just by the increase in bulk of the gingiva that this is being caused. Okay, formed. Whereas in periodontal pocket or true pocket, this is marked with the destruction of the supporting periodontal tissues. Okay. And similarly, in suprabony pocket and infrabony pocket, one thing which you can write is with the how it is related with the base and the crest of alveolar bone. And then the pattern of bone destruction. In suprabony, it is horizontal. You can see here. It is horizontal. Whereas in infrabony, it is vertical. Okay. And about the transeptal fibers. Transeptal fibers are actually gingival fibers, or you can also classify the periodontal fibers, but these don't have alveolar bone attachment. They run above the alveolar bone. So in suprabony pockets, they run in the same horizontal pattern itself. Okay, horizontally in the space, in interdentally they move, they run. Whereas in infra-bony pocket, their orientation will be changing from horizontal to oblique pattern because the bone itself, the shape itself has been destroyed like that. So the orientation of fibers also will change. Okay. And then according to the number of surfaces involved, it can be classified as simple, compound, and complex. The simple one, as the name is, because when you clinically, when you see a case of perio, or even if it is in the college, you assess pockets, assessing each surface, right? In college, then we may assess 6 surfaces, buccal, lingual, and buccal, mesiobuccal, and distobuccal. And in clinical, maybe 4 surfaces we would draw: mesial, distal, buccal, and lingual. So if it is a pocket that involves only one tooth surface, it is called as simple. Okay, but it's very rare. And compound is the most common one, where it involves 2 or more adjacent tooth surface. Okay. And spiral, it's a complex one, where actually the pocket, it originates on one surface, twists around the tooth, and to involve even the furcation areas. Okay. And involving additional number of surfaces. And actually the base of the pocket will not be getting a direct communication with the gingival margin. So actually this is like a spiral, very complex. Okay, it originates on one surface and then twists around the tooth to involve even the furcation areas. And there is no direct communication with the gingival margin also. So this is kind of is called as the complex or spiral pocket. Then yet another 2 types of classification based on the soft tissue wall of the pocket as well as based on the disease activity. So based on the soft tissue wall, we can classify as, that is, a pocket has got tooth on one side and your gingival soft tissue on the other side, just like your sulcus, no? So, but the soft tissue, no, it can present itself as edematous or sometimes fibrotic. So then it is classified as edematous pocket and fibrotic pocket. Similarly, on the basis of disease activity also, you can classify as active pocket and inactive pocket. Okay. So when coming on to this edematous and fibrotic pocket, that is when I told you, where you can explain it in the periodontal pocket is a healing lesion, because this fibrotic pocket and edematous pocket, they represent opposite extremes of same pathologic process. Okay, but they're not different disease entities. They are pockets itself. They are periodontal. They are one classic sign of periodontal infection itself or periodontitis itself. But they represent the opposite extremes. That is, you all know that when the bacterial plaque comes, there is host bacterial interaction. So as a result of it, there will be distraction. There will be inflammatory change. So there, and there is always, uh, simultaneous reparative process also takes place on one side. Okay. So periodontal pockets, they undergo repair also. This is like a fine balance between the both. Okay. So when this inflammatory changes predominate, then the pocket would appear as edematous. So then it gives off the edematous pocket appearance, where the soft tissue would turn bluish red or soft, spongy, friable, smooth, shiny surface and all that. Whereas if the reparative phase is the predominant one, then it is a fibrotic pocket wall. It will present as a fibrotic pocket wall with firm and pink color, which is actually shows a relative predominance of newly formed connective tissue cells and the fibers. So that is the explanation for it. And then based on the disease activity, means always this periodontal pockets or periodontitis, they have this periods of exacerbation, a period of activity, where there will be active bone destruction, connective tissue loss, and maybe suppuration, bleeding, and all that associated with it. And also a period of quiescence, inactivity, okay, where the inflammatory response is less and less bone loss and less connective tissue loss. So that is the explanation, and that is all about the classification of pockets. Okay. So all this content, no, this is from Carenza or I know most of the UG days, like we follow. I have cross-checked with Shantipriya Reddy also. Most of the contents are there in Shantipriya Reddy also. Okay, and it is all from Carenza. Just that I organized it. That's all. Okay. So in case if you want these presentations, you can ask me, like I can give you that for your, if it will help you for your studies. Okay. So then coming on to diagnosis, how do you diagnose a pocket? First, by the clinical features when you see a patient. Then you can definitely, the most reliable method is probing, isn't it? So you have to write about that also. The clinical features, all the clinical features similar to gingivitis can be written. Additionally, something which is there is tooth mobility, diastema formation, and symptom. The patient may tell localized pain or pain deep within the bone and a foul taste. Okay. And then the probing, when it comes to probing, with the use of periodontal probe, it is the most reliable method for detecting a periodontal pocket. And then pathogenesis. So regarding pathogenesis, I have formed a flowchart like that. So if you want this flowchart, I can share the screen. I mean, the screenshot of this itself. But if you want, you can also you read it and form a flowchart according in your language so that it will be easy for to put across with saving a lot of time. So about the pathogenesis means how a pocket is formed. That is what we explain in it. So how it is formed? First, it begins with the bacterial plaque coming onto the tooth surface, right? So one first bacteria will come and stick onto the tooth surface. Then it will, the host, it doesn't stay still, no, it starts responding to it. So as a result of it, there will be inflammatory changes that happens in the marginal gingiva. So as a result of the host bacterial interaction, lot of mediators will be produced and it starts causing distraction or degeneration of the first what gingival fibers, the collagen fibers, and then the connective tissue. First fibers to get destroyed is the gingival fibers. Okay, then it progresses to periodontal fibers. So first bacteria will come, and there will be a host response, and as a result, there will be inflammatory change. So marginal gingiva get inflamed and edematous, and there will be destruction of the collagen fibers also. So as a result of the destruction of collagen fibers, and as a result of edematous changes in the gingiva, a gingival pocket will be formed first. Okay. So this gingival pocket is what? A deepened sulcus, where it favors the growth of anaerobic bacteria. So there is a transition from the coccoid cells to rod-shaped cells, anaerobic organisms. And then more and more anaerobic organisms, they grow and proliferate, as a result of which more host response also happens. So large number of PMNS, the first line defense cells, no, they come into action. Okay. And when the number of PMNS, they go beyond 60%, then slowly, the junctional epithelial cell starts losing its cohesiveness, the attachment, and they starts to recede apically down, causing periodontal pocket formation with attachment loss. Then it paves way for more plaque accumulation, more bacterial growth, and so more and more attachment loss and bone loss. So that is the pathogenesis of pocket formation. In Chantipriya, they have given a diagram also. You can very well, if you are a good drawer, you can draw this also for representing each of the stage. And then coming on to the histopathology of pockets. Okay. So coming on to the histopathology, you have you basically what all things you can see under microscope in a pocket. Okay. Your gingival tissue, where if okay, as well as the root surface wall. Okay, so when you observe the gingival tissue, you can see the epithelium, then you can see the junctional epithelium and the connective tissue. These are the three areas where changes can be seen. So the epithelium, if generally spoken, like at the crest, that is at the top portion, it remains like not much affected. Okay, but just that the retipex will be very prominent. And in the junctional epithelium, what happens is generally the size, the length of junctional epithelium itself gets reduced from about 500 microns to 50 to 100 microns. And there will be degenerative changes and ulcerations and everything can be seen in the junctional epithelium. And regarding the connective tissue is what lamina propria, where the blood vessels and everything is there. So there is an increase in number of blood vessels because of the edematous change. So dilation and engorgement of blood vessels will be there, and more of defense cells, that is PMNS, and more of, in a chronic periodontitis pocket, that there will be more of lymphocytes, mainly plasma cells distributed in the connective tissue. And also it will show areas of degeneration and necrosis. Okay. So this will be the changes that will be there in the connective tissue. And then this is under normal microscope. Okay. When you see it under an electron microscope, you can see the microtopography of the gingival wall. Okay. That is, and these, you can see various areas and they constantly change also. Okay. So what are the areas that are seen? There will be a area of relative quiescence. That is an area where not much of any change or relative inactivity. So that will appear as a flat surface relatively with light depressions. Okay, with occasional shedding of the cells from the region. So that is the relative quiescence. And an area which is relatively inactive. And soon, just adjacent to the area, you can see an area of bacterial accumulation where maximum bacteria, they uh, get embedded into the depressions and all, and there will be bacterial clumps and debris and everything in this spaces. And you can see cocci, roots, filaments, spirochetes, everything in that area of bacteria accumulation. And then you will see the adjacent to the area of bacterial accumulation, of course, there will be leukocytes, emergence of leukocytes, area of emergence of leukocytes. And then there will be area of leukocyte bacterial interaction. Okay. So once the leukocyte emerge, what happens? There will be interaction between the bacteria and the leukocyte. That kind of area will also be there in the gingival wall. Okay, when you see it under electron microscopy. So that is, numerous leukocytes you can see covered with bacteria. Okay, that is maybe in the apparent process of phagocytosis. And then there will be area of intense epithelial desquamation where, semi-attached and folded epithelial squams can be seen, sometimes partially covered by bacteria. And then area of ulceration, area of hemorrhage, which exposed connective tissue and numerous erythrocytes. This is all with regard to the microtopography of the gingival wall in a pocket. And similarly, root surface also can be seen microscopically, where you can see there will be changes in the cementum. You can see degeneration of the cementum, the fibers, degradation of the fibers, and fragmentation of the cemental surface, necrotic cementum. Uh, Generally speaking, clinically, it will result in softening of the cementum. Okay, which is asymptomatic, but we run with a prop which will give you pain. Okay. And regarding the surface morphology of the tooth, with relate a tooth surface with related to pocket, adjacent tooth would have some calculus associated with it, right? There will be some amount of calculus attached to it. And above the calculus, we know always there will be some attached plaque will be there. Okay. And then there will be a zone of unattached plaque, then junctional epithelium, then partially lysed connective tissue, and then intact connective tissue. So these are the 5 zones that can be seen at the bottom of the, pocket in the tooth wall adjacent to the pocket. Okay, so here you just need to know that uh, zone 5, we name this as 1, 2, 3, 4, 5, and among which 3, 4, 5 zones. Okay, from unattached plaque, junctional epithelium, and partially lysed. These 3 ones are called as a plaque-free zone. Even though they have this unattached plaque included in it, this is called by the scientist who proposed this as a plaque-free zone. Okay. So then finally, to the conclusion part, you can enlist the pocket contents, which comprises of majorly microorganisms and their debris, and all what is there in the oral cavity and the gingival sulcus, includes gingival fluid, salivary mucins, food remnants, desquamated epithelial cells, leukocells, pus cells, everything. Okay. Finally, the management. How do you manage? You just have to enumerate the steps. That is, first by non-surgical treatment, scaling route planning, medication systemically as well as local drug deliveries can be given. And if it is beyond a level like the critical probing depth and all, you will have to proceed with the surgical management. Okay, which includes what all? Curettage, gingivectomy, various flap techniques. Okay, so that is all with regard to pocket, its treatment aspect, then the histopathologic features, classification. So if question comes from any of these areas, I think you will be able to write now. Okay. So now the next important question. So we are nearing the surgical aspect, different surgicals. The periodontal flap. Okay, and the most frequently asked question from periodontal flap is define and classify periodontal flap. Write in detail about modified Whitman flap. Okay, So this modified Whitman flap itself has been like, asked many times as a short note and brief note and all. And also this question, this define and classify periodontal flap, this has been asked, I think, twice when we take the previous 5-year papers and thrice when we take from 2016. Okay, so again, coming on to the contents. Okay, when a flap is being, that is you something about the flap is being asked, you have to again start with introduction, end with conclusion. Okay, then in between, whatever that is being asked in the question, that should be there. So definition, classification, indications of flap surgery, and then different flap techniques, then healing after flap surgery. Okay, so the advantage of this is like, even if a modified Widman's flap is asked, it has a short note. You can first give the definition of periodontal flap, then you can, write modified different flap techniques you can enumerate, and then you can write the indications of flap surgery for the modified Whitman's flap also, because any flap surgery indication would be, it would go with any of those techniques, right? And then healing after flap surgery also can be written for modified Whitman's flap. Okay, and then conclusion. So as introduction, what I have written was like periodontal flap surgery, it's one of the most frequently employed procedure. You can write whatever, I think I've taken from Shantipriya Radioli, some introduction, which is, which you feel has some content in it. Okay. So this is one of the most frequently employed procedure, particularly for what? For eliminating or reducing moderate to deep pockets. Okay. That is why this flap technique is being done. So this includes what? Intentional incising of gingival tissue. Okay, with the purpose of controlling or eliminating periodontal disease. So definition, then coming on to the definition, you can write is, what is a periodontal flap? Okay, it is a section of gingiva or mucosa, the underlying tissues. For what? To provide visibility and access to the underlying structures, which are the bone and the tooth surface, um, uh, is what is periodontal flap is. Okay, that is for proper instrumentation. We need to gain access and visibility, and that is why we, reflect a flap. So this is a section of a gingiva or mucosa surgically elevated from underlying tissue. So here an incision is given, and this gingiva or mucosa, it is being reflected, okay, surgically separated from the underlying bone to gain access to the bone and the tooth surface. And what are the indications of this? This is to gain access for instrumentation and also to reduce the pocket or eliminate the pocket. And then also to do various resective regenerative procedures, isn't it? That is to reshape the soft and hard tissues, that is gingiva as well as the bone, to attain a normal physiologic contour so that it would enable the patient to uh, give a good oral maintenance. Okay. A physiologic architecture, to bring about a physiologic architecture, which is otherwise the resective surgical procedures. And then also, this is being reflected to give way for regeneration surgeries. Okay. That is regeneration of alveolar bone, periodontal ligament, or cement. So now coming on to the classification, you can classify this basically into 3 types based on the thickness of flap or bone exposure. You all may be knowing it. That is full thickness flap or partial thickness flap. And then placement of flap after surgery. That is after the surgery, either you can suture it back to the original position, or you can, this flap, this freely moving tissue, this can be displaced from the original position to a new position. So that is on the basis of which it is being classified as non-displaced flap and displaced. And based on the design of the flap, whether it preserves the papilla or not, it is classified into conventional flap or papilla preservation flap. Okay. And then under each of this, you will have to write what the relevant points. Okay. That is in full thickness flap. What is full thickness flap? Okay. It includes the entire, all the soft tissues. Okay. And it exposes the underlying bone. It includes the gingiva, connective tissue, gingival epithelium, connective tissue, and the periosteum is being reflected. Okay. And to expose the underlying bone. So this is indicated in what scenarios? where a bone surgery is required, this must be done, right? We have to gain access directly to the bone. So it in resective or regenerative procedures, we prefer full thickness flap only. Whereas in partial or split thickness flap, only the epithelium and a portion of connective tissue is being removed. Okay. Or, I mean, reflected. And a portion of connective tissue and the periosteum, it remains over the bone itself. Okay. So this is basically done in cases where you need that extra movability for the flap, okay, to displace it, to pull it and keep it somewhere, like push, വലിച്ച് എവിടെയെങ്കിലും വെക്കേണ്ട പോലത്തെ കേസസ് വരുമ്പോൾ you need that stretchability and movability, no? So അങ്ങനത്തെ കേസസിലാണ് you will have to go for a split thickness or a partial thickness flap. Okay, so in case of displaced flap, like laterally displaced, coronally displaced, apically displaced, all these cases, you will have to prefer that. And also in cases where the marginal bone, if it is very thin, raising a full thickness flap might end up in dehiscence or some bone loss in that region. So to avoid that, you can raise a split thickness flap. Okay. And then the non-displaced and displaced, the names itself suggest what they are. And next is the conventional flap and the papilla preservation flap. The conventional flap, I'll explain it with the figure. It is nothing but you give the clavicular incision and you split the papilla interdentally so that one half of the papilla goes to the labial side and one half of the papilla goes to the lingual side. So the papilla is split here in the conventional flap. Okay. So this is indicated in cases where actually the interdental space is very narrow, means only option to go is with the conventional flap only. Okay. Whereas in papilla preservation flap, we just give the clavicular incision all around the tooth. That is between in the sulcus space, no, between the tooth and the gingival margin. We place the knife and then we sever the attachment. That is the clavicular incision. And we make sure that the interdental papilla is not split. Whereas they're actually just 5 mm away from the crest of the interdental space, we give a semi-lunar incision like this. And then we reflect the papilla to one of the flaps. Okay, so papilla preservation flap is that in which the papilla is preserved or it's incorporated in one of the flaps. Okay, so in areas where aesthetics is a concern, in anterior region, and also where regenerative surgical techniques are the ones which we are undergoing, we prefer this papilla preservation flap only. That is because, so that you can see here, there is a bone defect, mesial 2, maybe this is a premolar. Consider this is a premolar. So here, the papilla has been reflected. I mean, it's preserved. So while placing it back to the original position, this flap itself will act as a coverage for the graft or the membrane that is being placed in the regenerative procedures. Otherwise, what happens in the conventional flap, the split would be here. So suture would come directly above the graft or the membrane, which causes its exposure. So that is why we prefer papilla preservation flap for regenerative purposes. But one thing which is important is this is possible only in cases where adequate interdental gap is there. Only then that we'll be able to reflect the, papilla to one side. Through the interdental space only we can reflect, no? So adequate space must be there to take it out. Okay. So I hope that much is clear. And now coming on to the incisions. So when a periodontal flap is asked and flap technique is asked, you cannot go forward without incisions. So you have to write about incisions. So for conventional flap, basically we have horizontal incision and wherever necessary, we give vertical incisions. But all the flap techniques have 3 horizontal incisions. Okay, which we name it as first incision as internal bevel incision, second as clavicular, third as interdental. The picture itself will show you. Okay, so the first one is the internal bevel incision. Okay, this is directed to the crest of the bone and it is, it is given in such a way that, few millimeters away from the gingival margin. And then you have the and this is given with number 11-15 blade. And then you have the clavicular incision. That is, you place the BP blade handle between the tooth and the gingival, in the sulcular space. And then you sever the attachment. So once after the internal bevel and the clavicular, you get a wedge of tissue here, which consists of pocket lining or maybe a pocket wall. So then you give interdentally, you sever the attachment and take off the tissue with a curette. So that's how the procedure is being done. So these are the 3 incisions for which you can make the diagrams also for the exam. And then wherever necessary, vertical releasing incision is given. So that is, this vertical releasing incisions are actually given in areas where you need this extra movability of the flap. Okay. Or to, displace it apically, laterally, or coronally, that extra mobility or stretchability when you need, or also for sometimes, for access, if it is a very deep pocket and all, just by the minimum, elevation, you will not see the depth, the base of the pocket. So you might be want to give that vertical incisions also. So this vertical releasing incision, when you give, what you have to bear in mind is that this vertically it is given. So it shouldn't be given in the middle of the papilla in a way like it will split the papilla. And also it shouldn't be given directly over the root surface or the radicular surface, because in both of these ways, it would compromise the blood supply. That is the reason. It should always follow line angle. It should be given along the line angle of the tooth surface or the root surface. Okay. And also, just I have given the explanation already. In all these, I hope you understood the incisions. So under each of these headings, you will have to write one sentence. Okay, how it is, with what it is being given, like the blades you can mention and how it is being given. Okay. So, and about internal bevel incision, when we speak about, actually it is based on the difference in the orientation as well as the distance from the gingival margin, the internal bevel incision is given. Okay. That is actually what determines the different types of the flap technique. Okay. Again, I'll repeat. It is basically based on the difference in the orientation of internal bevel. These are all internal bevel incisions only. Okay. But if this internal bevel incision is given about 0.5 to 1 mm away from the gingival. This is a margin, no, where my pointer is there. So this away from the gingival margin, it is the modified Whitman's flap. But if it is given, maybe more than 1 mm or to 2 mm away from the gingival margin at a distance to the base of the pocket with an intention to completely remove the pocket, then it is the undisplaced flap. Whereas in apically displaced flap, we give it at a distance very close to the gingival margin with an intention that only the pocket's lining is being removed here. Okay. So for that, you need to know there is something called as pocket lining and pocket wall. Okay. Pocket lining, no, pocket in that circular epithelium is there, no? That epithelial lining is the pocket lining. Whereas pocket wall comprises of this lining as well as this entire tissue, the tissue lateral to the lining. So in apically displaced flap, we give it with the idea to maximum preserve this keratinized tissue and width of attached gingiva. And we just remove the lining, and then this flap is apically pulled down and sutured. Okay, where modified Whitman, it is at a distance like 0.5 to 1 mm away from the gingival margin that this incision is given. So it is all, the difference in each of the flap techniques is basically based on the orientation of internal bevel incision and also the distance from which this is, it is given from the gingival margin. Okay. So then the different flap techniques, it includes modified Whitman, undisplaced flap, apically displaced flap. Okay. So in this, modified Whitman and apically displaced has been asked repeatedly for your exam. Okay. As short notes. So about modified Whitman, as I've already told you, this Ranchford and Nissel is the one who proposed this. So you need to give this under bracket and highlight it, okay, with a different pen, color. And then you can write the step by step. The steps are given in Shantipriya as well as in Karansa. You can follow either of it, which you feel like easy to be followed. But the basic thing is, basic points I'll let you know now. Okay, first, I've already told you the internal bevel incision. That is the first incision. That is given 0.5 to 1 millimeter away from the gingival margin and oriented towards the crest of the bone. Okay. And then, gingiva is reflected with the periosteum little bit. And then the clavicular incision is given. That is, between keeping the blade in the sulcular space and severing the attachment here. And then you can, and all around the tooth, you have to move the blade, and then interdental incision is given so that this wedge of tissue will be removed. And then finally, you will reflect the flap. You can do the debridement, everything, and suture it back to the original position where it was. So this is an example for undisplaced flap also. Okay. And here where the pocket lining is also removed. So it's a pocket elimination. So it has got the advantage that it, helps in gaining access, and also it removes the pocket. It eliminates the pocket lining. Okay. And also, in case if you need to do some resective procedures where bone recontouring and all has to be done, that also can be done before suturing. Okay. Then with regard to apically displaced flap, as I've already told you, the difference with the modified Whitman is that this is given, the internal bevel incision is given to the crest of the bone itself. But, at a distance, keeping in mind that, we should preserve this keratinized tissue or attached gingiva to the maximum. Okay. So that it is as close as to the gingival margin. And of course, not more than 1 mm from the crest of the margin. That is what is written here. This is made, and to preserve as much as keratinized gingiva and attached gingiva as possible, and it should be not more than 1 mm from the crest of the gingival margin. But it is not even 1 mm as close as to the gingival margin that you have to keep this incision. And then you give the second incision, that is the clavicular incision, and then the interdental incision, and this portion will be removed. And then again the difference comes in here. That is, after removing this, you can reflect the flap, you can do all the degranulation, root planning and everything. And if resective surgery has to be done, that also has to be done. And then the difference is that the remaining pocket wall, right? This is brought apically down. So for apically bringing it down, you need to give vertical releasing incision. So that is why step 3 includes vertical releasing incisions, which extends beyond the mucogingival junction. Always when you give vertical releasing incision, no, you have to extend it beyond the mucogingival junction, that is to the loose alveolar mucosa. Then only, that extra movability can be obtained. So that is being done. And then this is being sutured, pulling it apically down. And when you suture it, some important point that has to be written. This point is important. The edge of the flap is sutured 2 millimeters apical to the alveolar crest. Okay. That is when after healing, it gives a good contour. Okay. So this is also the change that is there from the modified Whitman. So it has got the advantage. What all advantage? It eliminates the pocket, well and good. It preserves the keratinized gingiva to the maximum. And also, another feature is that it preserves the attached gingiva also. And it can be used in areas of insufficiency of attached gingiva. Why? Because, actually this pocket wall, no, which is apically pulled down and sutured, gets converted to attached gingiva after healing. Okay, with 50% shrinkage. So actually, in a way, it is increasing the attached gingival width. Okay, and also it results in crown lengthening. So these are the advantages. And then finally, healing after flap surgery. So soon after, when any healing comes, you'll not remember the entire thing. So what you need to do is you write the time period and relevant changes that happens within the time period. That is only sufficient. Okay. So soon after suturing, what happens within 24 hours, this, fibrin blood clot will be formed between the flap and the root. That is what happens. And in 1 to 3 days, the epithelial cells, they start migrating over the border of the flap. And in 1 week time, re-epithelialization takes place. Always re-epithelialization takes place in a week period. Okay. So that is epithelial attachment happens on the tooth surface with the help of hemidesmosomes. And then in 2 weeks time, the collagen fibers, they start to appear. Okay. Parallel to the tooth surface. And then in 1 month period, complete healing takes place with fully epithelialized gingival crevice. And now, as a conclusion for the flap, you can write it as post-operative plaque control is essential for the successful, whatever procedure we do, how much ever neat we do with the flap technique, it is the success of the treatment. It depends on the post-operative plaque control. Okay, so that is what I have written as conclusion. If you have a better statement, you can write it even that. So now we have seen pockets, we have seen the different flap techniques. Now coming on to the mucogingival surgical procedure, where the question has been asked with regard to gingival recession only. But few of the grafts are being asked as short notes or brief notes. Okay. For example, these questions: free gingival graft, connective tissue graft, lateral pedicle graft. These are the questions, and among which free gingival is the one that has been repeatedly asked. So I think this is all what you can expect from the mucogingival surgical procedures. Gingival recession, define and classify. Write in detail about FGG for the recession management. But in this description, I have described about the connective tissue and the variants of it, and the lateral pedicle graft also, so that brief notes also will be covered. Okay, excuse me. Okay, so coming on to the contents. So the question is, define and classify gingival recession. So you can write introduction, definition. Then there is something called as types of recession and classification, etiology, clinical significance, then rationale of treatment. Why do you need treatment for gingival recession? Then the various treatment techniques. And among that, what is being asked? If FGG is asked, you can write about FGG particularly, a little bit detailed. And then if something else like subepithelial connective tissue is asked, that you can give in detail. Okay, and then conclusion. So this will be the contents. And let's move on. Okay, so with regard to gingival recession, gingival recession, it is one of the common finding both in dentally aware population as well as those with poor oral hygiene, isn't it? Because of faulty toothbrushing, excess force that is being applied is seen in both the categories of people. And also with age, it seemed to increase. Okay, the prevalence, extent, severity, everything seems to increase with age. And this gingival recession, actually, it refers to what? It refers to the location of gingival margin or the position of gingiva, isn't it? Not the condition of gingiva, whether it is inflamed or not, or whether it is diseased or not. It is not the thing. It just refers to the position of gingiva or the location of gingiva on the tooth surface. And with regard to position of gingiva, when we speak, there is something called as actual position and apparent position of gingiva. Apparent position is what we see, that is with related to the gingival margin. Okay, that is the level of the crest of gingival margin is the apparent position, whereas the actual position is the level of epithelial attachment onto the tooth surface. Okay, that is what is the actual position is. So the severity of recession, it is measured depending on the actual position of gingiva, not the apparent position. Okay. So that is what my introduction had. Then coming on to the definition, it is defined as exposure of root surface by the apical shift in the position of gingiva. And you can draw a diagram also. Then coming on to the types. Okay, you can have localized and generalized depending on the distribution. Localized is what? It involves only one tooth or few teeth or group of teeth. Generalized when it is distributed throughout the oral cavity. And similarly, you can have visible recession and hidden recession. Okay, that is, here again, visible recession is what that is clinically visible, observable, and hidden is what is covered by the gingiva, but then still there will be loss of epithelial attachment. Okay, so this can be measured only with a periodontal probe. Okay, so this is given by Louis and Salt in 1980. So where visible recession is measured from the cemento-enamel junction to the soft tissue gingival margin. What is clinically visible here? Okay, this much portion. Whereas this hidden recession is because of the loss of attachment and it's within the pocket. Okay. Then coming on to the classification, you have a lot of classification for recession, but at least you should know Miller's classification is a must know, and then another one or two. Okay. So here I've written two, that is Sullivan and Atkins, the most easiest classification, that is deep, narrow, deep, wide, shallow, narrow, shallow, wide. You can draw a picture also. And then Miller's classification with relation to the extension into the mucogingival junction, and also considering the degree of soft tissue and hard tissue loss, right? So for that, I think all of you would know Miller's classification, right? That is, one which does not extend up to, it just extends up to mucogingival junction, but not into the mucogingival junction, then it is class 1. And then if it extends beyond the mucogingival junction, it is class 2. In both these cases, there will be no soft tissue loss or interdental bone loss. And in the third one, there will be some soft tissue loss and interdental bone loss, and also this extends beyond the uh, mucogingival junction. And in the fourth, it extends beyond the mucogingival junction with severe bone loss and attachment loss. Okay. So speaking about the prognosis of the treatment, about tooth coverage procedure success, class 1 and 2 shows 100% root coverage, whereas in 3, it is almost like 70%. And in 4, it is very poor. Okay, so it's less than 10%. So that is the Miller's classes. So we have dealt with the classification part also. Now coming on to the etiology. There are various etiological factors that leads to recession. And I have classified it into like 6 major, that is local factors, which includes your plaque and calculus. Then mechanical factors, which includes the faulty tooth brushing, trauma from occlusion, gingival ablation, that is, frictional forces from the soft tissues. And then habits like smoking has shown to increase the prevalence of recession. And various anatomic factors like, dehiscence, fenestration, malpositioning of the tooth, frenal attachment, abnormal frenal attachment if it is present. And if narrow zone of attached gingiva is present, that also will lead to, recession. And then iatrogenic factors, which are what are iatrogenic factors? That which are induced by, accidentally by the clinician. So like orthodontic tooth movements or improper or faulty restorations with overhanging restorations. So they all can cause recession of the gingiva. Then finally, the physiologic factor, which is age, is one of the factor. It seems to increase with age. And coming on to the clinical significance, why this is clinically significant? Why recession is clinical? Because when recession happens, there is the apical shift in the, the attachment. So in a way, actually, this root surface get exposed to, right? Exposed to the outer environment. So as a result of which, there will be increase in sensitivity. Okay. And root caries, chances of root caries was more. Hyperemia of the pulp. And then also it becomes difficult for plaque control. Like patient finds it difficult to maintain the plaque. And also it is unaesthetic, appearance wise also it is unacceptable, unaesthetic ones. Okay, so these are the clinically how this is significant. And so the rationale of the treatment. So when you take up a treatment, that mainly it is with regard to like the primary etiological factor. Okay. And then we have to consider the primary etiological factor first. And why do we do this treatment? For getting adequate root coverage, so that, and also, so that for making it aesthetically good, and also to, reduce the sensitivity. And if it is because of inadequate zone of attached gingiva, to create a band of attached gingiva. So that is, these are the various rationales for gingival recession management. Okay, so coming on to the treatment, you have non-surgical management and surgical management. So as I've already told you, first is the correction of primary etiology. And then, if it is because of a faulty restoration and all, you have to correct the restorations or the crowns. And then if the patient is more concerned about the sensitivity alone than the aesthetics, then you have to go for desensitizing agents first. And then root conditioning, if it is because of aberrant frenal attachment, do a frenectomy. Then orthodontic correction can be indicated if necessary. And coming on to the surgical management of it, there are various procedures by which we can try to cover the denuded root surface. Okay. So here, if there is an inadequacy in attached gingiva also present with the recession, then it is the free soft tissue grafts that are being advocated. Okay. Because these free soft tissue grafts will also result in increase in width of attached gingiva. Whereas if there is adequate width of attached gingiva or adequate keratinized tissue that is present in the region, only thing is that there is some denudation, there is some root recession that has happened, then you can go for something called as pedicle soft tissue. I'll tell you the differences, okay, between each of it. So first of all, uh, okay, I'll tell you. That is, the free soft tissue means, graft means they are those portion of gingiva or the tissue that is taken from one donor side, a separate donor side, and is placed on totally different side, a recipient side. Okay. And so they completely depend on the vascularity of the recipient side on which it is placed. So they are completely separated from the donor side. Whereas pedicle soft tissues are those which has got their connection or the base connected to their original location itself. They are just displaced and placed over the recipient side. Okay. So coming on to the surgical management, this flowchart is very important. If you can also draw a flowchart or take a note of this, because this gives an explanation, okay, you know all the procedures. And also I have added the scientist who brought about these techniques so that it gives you an overall idea, and also it is easier for you to remember also. Okay, repeatedly seeing this flowchart. So when you see the surgical management, first you have the free soft tissue graft, which I've already told you, which includes a free gingival autograft, free connective tissue autograft, and then subepithelial connective tissue autograft. Okay, that three we will see. And coming on to the pedicle soft tissue graft, I told you, what are they? They actually, pedicle soft tissue grafting is, they have their base attached to the original, their location itself, and they are just pulled and placed onto this site of recession. So laterally displaced, coronally advanced, and semilunar coronally advanced flap. Okay, these are the major flap graft techniques which are done for the surgical management of gingival recession. And also pouch and tunnel is a variant technique where create a pouch like you know gap between the, in the site of recession, and then this free soft tissues would be placed in between. And GTR is also another technique, and there are different scientists, the names of the researchers have been also mentioned down, like who have introduced these techniques. It is always good and well, like if you can by heart the names also. So prognosis we have already told when we discuss about Miller's classification. So now coming on to the last part of the question, that is the free gingival graft. So we have dealt with the definition, we have dealt with the etiological factors, the rationale, the various treatment options, then the surgical treatment options. Now the free gingival graft. So what are free gingival graft? They are free soft tissue autografts. Autograft means the one that is taken from the same individual, okay, from a different side. So they are free soft tissue autograft, which are taken from the donor site, that include, okay, so there are different donor sites that can be, like from where this can be taken. So that is, it can be attached to gingiva or masticatory mucosa of edentulous spaces, and also palate. Palate is the most commonly, common area from which the graft is procured and placed on a recipient site to correct any mucogingival problems like insufficiency of attached gingiva, vestibular depth, as well as gingival recession. I have given this definition because, FGG was also asked as a short note. So for that, you need not confine to, gingival recession alone, because FGG is a free soft tissue autograft that is used for, correcting all the mucogingival defects like increasing attached gingival width, increasing vestibular depth, and also to cover the denuded root surface. But if it is specifically asked in relation to gingival recession question, you write that alone. Otherwise, you can write all the three. Okay. And then the technique of this. Okay, so this free gingival autograft was actually initially proposed to increase the width of attached gingiva. Okay, by somebody called as John in 1963. And later Miller, who gave off the classification for recession, gave off some modifications to this and used it to cover the denuded root surfaces with an increase in width of attached gingiva. So what is the technique, that also you will have to learn. And the important points when you write the steps in, preparation of recipient site and the donor site is that, the recipient site, okay, the aim is to prepare a firm connective tissue bed. Okay, so because it is onto which that the graft is placed, and the graft derives its blood supply completely from the donor side. I mean, sorry, recipient side. Okay, the blood supply from the recipient side. So that the recipient bed should be wide enough and highly vascular and a firm connective tissue bed to receive the graft. Okay, so that is the primary aim of preparation of the recipient side. And we raise a split thickness flap there. Okay, we just raise a split thickness flap because we need that connective tissue and blood vessels to be present there to provide innervation for the graft that is placed on it. So using a number 15 blade, the recipient site is prepared. Okay, first by giving horizontal incision, preserving the papilla, to the tooth, to the adjacent to the denuded area. And then vertical releasing incisions are also placed in such a way that, at least for the purpose of coverage of recession, if it is for this vertical releasing incision, whenever it is given, it should extend beyond the mucogingival junction. Okay. And if this is to cover the denuded root surface, make sure that laterally and apically to the area of recession, at least there should be 3 mm distance for the recipient bed. And if it is to cover the width of attached, to increase the width of attached gingiva, then when you do the vertical releasing incision, it should be, at least twice the desired width of attached gingiva. That is, if you are aiming to create a width of 6 mm, then, 3 mm, then you have to give this incision about 6 mm depth from the mucogingival junction. So that, because there will be some percentage of contraction that happens while healing. Okay, I'll repeat it. So when you say about FGG, you have to say this is initially brought about for the increasing the width of attached gingiva, and later some modifications was brought to cover the denuded root surface. And regarding the preparation of recipient site, you have to make sure that a firm connective tissue bed is prepared as recipient site to receive the graft. Okay. And with the number 15 surgical blade, prepare the recipient site, raising a split thickness flap. Okay. And then if it is for increasing the width of attached gingiva, put the vertical releasing incision to a depth which is, twice the desired width of attached gingiva, assuming that 50% contraction for the graft when it is healed. And if it is to cover the recession, then laterally and apically 3 mm distance should be there from the root surface, so that the bed will be adequately wide enough to receive the graft. Okay, then after this site is being prepared, you have to place an aluminum template approximating the size of, similar to the size of this recipient bed. And this aluminum foil template is then transferred to the donor site, which is normally the palate. And from there, this FGG is procured. Okay, so now see, this is the recession site. And then corresponding to the width almost, the aluminum template is being prepared. And then it is being placed on the palate. And then the FGG is procured. So here you see the epithelium with some amount of connective tissue is being taken from the palate site. And then the thickness of the graft, that is another major criteria that you will have to bear in mind when you perform these procedures, because if it is not adequately thick, it would cause the necrosis of the flap. If it is so much of thick, okay, then it doesn't allow the proper blood supply innervation to, neovascularization to take place between the graft and the recipient bed. So the ideal thickness is 1.1 to 1.5 mm. Okay, that should be the ideal thickness of the flap. So this is, sorry, not the flap, graft. Okay. So this is the pictures. So yeah, this is the poster. Then transfer and immobilize the graft by using sling sutures and anchor sutures, and then protect the donor site with the periodontal pack and an aluminum foil. And if the foil is placed, call after 1 week, take out the foil and repack it if necessary, and then call the patient back after 2 weeks. Okay, that is how this is being done. So preparation of recipient site and preparation of donor site. Okay, that Both of it you will have to know, and graft thickness is important. Okay. And then regarding FGG, you can write the indications, advantages, and disadvantages regarding any of these techniques. Okay, FGG, lateral pedicle, or even connective tissue grafts. For all of this, you can write all these things. Okay. So with indications, so once you understand what is the procedure being done, I think you can form it on yourself. Okay. For example, this FGG, it is what are the indications for the covering the root surface, denuded root surface, for increasing the width of attached gingiva, then increasing the vestibular depth. And, in case of dehiscence and fenestration, that is similar to that of recession, no? And also in areas of abnormal frenal attachment that you can do this because you are just raising the split thickness flap there, no? So the frenal attachment also will be relieved there. Okay, and what is the advantage of it? Its simplicity is the advantage, and it is able to treat multiple teeth. And also this can be used in areas with reduced keratinized gingiva or attached gingiva, because by doing this, we increase the width, no? So that is not a factor. Disadvantage is the two operative sites. So, and patient will have greater discomfort because of the same. And retention of the graft is also a challenge. But the major disadvantage for FGG is the color match. There can be a problem with the color match. And also on the donor side, since we are removing the epithelial portion also, healing is by the secondary intention, which can be painful. Okay. And also FGG, since it has come as a short knot, you should also know the variant techniques that are there in the FGG. One is accordion technique, other one is strip technique, then connective tissue technique, and a combination. So in accordion technique, it is nothing but the graft which is taken, no, on opposite sides of the graft, you give one slit without piercing the graft. Just, superficially, you give a split so that it increases the stretchability of the graft. Okay, expansion of the graft is achieved. And in the strip technique, it is nothing but small strips of 1 millimeter width of free gingival graft is collected, and then it is placed and sutured onto the recipient side. And connective tissue technique is a variant where actually in the FGG, what we did, the epithelium with the connective tissue is being taken as a graft. So in connective tissue technique, it was given by Eden. Only the connective tissue is being taken. We will come on to that because that is also asked as a short knot. Okay. So the reason why this was considered, okay, that is, okay, it would be good if you can take only the connective tissue and, place it as a graft, is because this connective tissue has a lot of viable cells, right? And genetic material, so that when it is placed on over the recipient bed, it has the ability to keratinize according to the location where it is placed. Okay. So that is why this is being used. So connective tissue graft, again, first it was described by Eden for increasing the width of attached gingiva. Then later, Levine is the one who proposed it for root coverage procedure. Okay. So, and the difference between these, because you shouldn't get confused, maybe because one place you will be reading this name Eden, and other place you will be reading Levine. So like you shouldn't get confused. Oh, this isn't it? These are two different things. No, it is the same thing, but for different scenarios, it has been used by different scientists or researchers. That is why the different names are there related to the same technique. Okay. So the difference between this technique and the free gingival graft is, I've already told you, the donor tissue. The free gingival graft, it is a layer of epithelium with a layer of connective tissue. Whereas in connective tissue graft, it is only the connective tissue. Okay. And so by using this graft for the purpose of root coverage, we overcame the disadvantages of the free gingival graft, the major disadvantages. What were the major disadvantages of the free gingival graft? Aesthetics was, color match was one of the disadvantage, and other disadvantage was the healing by secondary intention. So here both of it is, overruled with the use of connective tissue graft. How I'll tell you when I describe the procedure, or we'll directly go to the procedure. So here, as in case of the free gingival graft, we prepare the recipient bed. Only difference is that here there will be apically, there will be some mucosal border, which will be sutured using the gut suture. And then a root planning, scaling, everything is being done for the root surface. And then graft is obtained. And when you obtain the graft, This is the palate. Okay. So from the palate, a parallel incision to gingival margin is being made. And then you see here, only connective tissue is being taken out. And then it is being sutured. So epithelium remains intact. So healing happens with primary intention. So patient discomfort will be less. Okay. So that is what. So again, you can write the indications and, advantages and disadvantages. Here, indications can be same for the FGG itself, whereas in advantage, you can write healing by primary intention. You can add on that, and less patient discomfort can be added. Color matching is better. This three things can be added. Okay. From that was there in FGG. And in disadvantage, you have to take out those things which were there in FGG. And only thing is that this also has two operative sites, isn't it? So that discomfort is there. Okay. So I hope you are clear with the differences between FGG and connective tissue. Okay. And another variant of connective tissue is subepithelial connective tissue, which was introduced by Langer and Langer. So this technique, what is the difference between the previous two techniques is that in the previous two techniques, we take off the graft and then we suture it, stabilize it, and a periodontal pack is given. So the complete blood supply for this graft is obtained from the recipient bed underneath, right? But in subepithelial connective tissue, what happens is what he proposed was, first of all, for performing this technique, this was exclusively for root coverage alone. Okay. The earlier two techniques, it was introduced for increasing the width of attached gingiva. Later modifications was brought and used for root coverage procedure. But this technique was mainly for the root coverage alone. And this technique needed, adequate gingival thickness to be performed, or width of attached gingiva should be there. Adequate keratinized tissue should be there, and vestibular depth all should be there for performing this. Why? Because, in this technique, actually, a split thickness graft of sufficient width is taken. Okay. So that, once after this connective tissue is procured from the donor side, then this connective tissue is placed between the, it is placed on the recipient bed over which the split thickness flap is placed and sutured. So it gives the blood supply from both ends, from the recipient side as well as the split thickness graft which is placed above. That is why it is called as, a bilaminar technique, where, a bilaminar vascular environment is provided for this connective tissue, that is the graft that is being placed. I hope you understood. I'll explain it with the picture so that I think better you will understand. So in this technique, so adjacent to the, I've already explained that. So the procedure I'll show with the pictures. Okay. These pictures I've taken from SATO textbook for giving you a better idea. Okay. So on what has actually been done. So here actually these are the areas of recession, right? So horizontal incisions are first made at the CEJ. This is the CEJ level at the CEJ in such a way that the marginal gingiva, the adjacent tooth is preserved, and also the interdental papilla is also preserved. And then the vertical releasing incision is given to the depth of mucogingival junction. Okay. And then a split thickness flap of adequate thickness. See here, the BP blade is inserted, and then a split thickness flap, that is epithelium with the connective tissue, is being reflected so that there is a bed with high vascularity, okay, underneath the recession site. But sufficient width of gingiva should be there if you need to split it and reflect it, right? So that is why I told it is indicated only in areas where adequate width of keratinized tissue or width of attached gingiva is there. Okay. And then the split thickness flap is reflected. And then from the donor side, you procure the connective tissue. Okay. So the connective tissue is procured and it is placed on the donor side. Recipient side. This connective tissue that's procured is placed on this recipient side. And this flap, it is placed back over the connective tissue. That is connective tissue graft, which is procured. And then this is sutured. So that this graft survival rate is so high because it has blood supply from underneath as well as above the flap, from above the flap. So it is sutured. Okay, so that is what is the difference between subepithelial connective tissue and the other. So this, since because it has blood supply from both the ends, it is called as a gold standard. And also this is a connective tissue graft, no? So it gives good color match also. Okay. And also healing at the donor site is by primary intention. So when you write the indications, you should mention it is only possible in areas of adequate thickness of gingiva, vestibular depth, and that has to be mentioned. And in advantages, you can write increased blood supply for the graft, dual blood supply. Okay. In disadvantages, two operative sites are there. Okay. Then the last among the flap, which is being asked as a short note, that is lateral pedicle graft. Okay. This is This is an example for displaced flap and pedicle soft tissue graft. And this is indicated in areas where there is isolated denuded root. Okay, where you will have to cover one or maximum two root recessions. Okay. And this is indicated only in this technique. What we are doing, we are pulling soft tissue from adjacent space to the recession site. So there should be adequate width of gingiva at the donor site adjacent to the recession. Okay, and it's only indicated, I've already told you, in places where adequate vestibular depth and adequate keratinized gingiva, everything is there. And the advantage is that it is only one surgical site. And since it's a pedicle graft, it has its base attached to the original tissue. So vascularity will be more. But the disadvantage is that, when you, in the adjacent site, there can be chances of dehiscence and fenestrations. And it is not indicated for cases more than two teeth. Okay. And also it cannot be done in places with inadequate attached gingiva. Okay. So this is the thing, and this is beautifully given in Shantipriya, ready, so you can follow it up. So this is the area of recession. So first of all, you have to prepare the recipient site. That is a highly vascular bed has to be prepared like the other graft surgeries. Okay. That is around the denuded root surface, connective tissue will be exposed. And then adjacent to the denuded root surface, a vertical releasing incision is given and a split thickness flap is, reflected from here. And this portion, it is, taken and sutured it over here. This is how this procedure is being done. Okay. And you can either raise a split thickness flap or full thickness flap depending on the thickness of the gingiva. But it is preferred that a partial thickness flap, so that in the donor side, healing would be better. But in case if the gingival thickness is very less, you can go for a full thickness flap also. Okay. So this is it. And one thing while raising the flap that you will have to bear in your mind is, here, no, at the apical distal end of the flap, the donor tissue, there can be tension when you try to displace it to one side. So to avoid that, a small oblique incision is placed, given at the base of the flap. And then it is being reflected to this side. Okay. And then it is being periodontal pack is placed inclusive of the donor site and it is secured. So this is the clinical picture. Okay, so the recipient site here, this is the recession site. So here you have, cleared, made a vascular bed, and then this tissue, the split thickness flap is being reflected and is brought to this recipient site, and it is sutured. Okay, here. So the variant techniques are like, there are variations to this. This is also given in Shantipriya only. I'll just explain it so that you will, while reading, you will better understand it. So in the variant techniques, it is nothing but two techniques. That is, one is where, an oblique incision is placed over the recipient site. Okay, an oblique incision is placed like this over the recipient site. And that is because then that will provide a wider flap to be reflected, no? So that will increase the survival rate of the, the graft or the flap that is being reflected and sutured. And the second variant is that you can see here, the marginal gingiva of the donor tissue that is, kept intact here. Okay, that is excluded from the pedicle graft that is being procured. Okay, in the donor side, the marginal periodontium is left undisturbed so that any chance of dehiscence or bone loss from this marginal area, usually the margin has thin bony plate. So there can be chances of bone loss and recession to happen there once this is used as a donor flap. So this is being preserved and then it is being sutured to the recipient. These are the two variants that is being given in lateral pedicle. And what are the reasons for the flap failure? As I've already told you, when you take this flap and put it, stretch it and put it to another place, there can be tension at this border, for which we give a slight oblique incision here so that the tension is relieved. Otherwise, if there is tension, that can lead to flap necrosis. And also, if there is not of adequate width, that will also lead to flap necrosis. And if the bone is exposed, lead to failure in that healing of that region and poor stabilization. These are the reasons for pedicle flap failure. And now coming on to the conclusion of recession. Management of gingival recession and its sequelae, it is based on what? A thorough assessment of the etiological factors first. First, remove the etiological factors and then also look into the degree of involvement of the tissues. And then careful selection and surgical management is critical for a successful outcome when you do, gingival recession coverage procedures. Okay. And now we are coming on to the last portion of the surgical part, that is related to osseous defects, osseous surgeries, and various regenerative surgeries. But a lot of questions have been coming from time to time. So you can see from 2016 to 2024, like different forms, questions have been asking. But you will have to have an idea on all these topics. You have to, formulate your own answers, assimilating the knowledge which you gain from all these topics. Okay. Because see, here one question is regarding classify osseous defect, add a note on autograft and allograft in the treatment of osseous defect. So you need to know what are the different osseous defects, what are the different osseous surgeries, and then you need to know about the regeneration here. Then, because graft, they come in regeneration only, So you need to know, you have an idea on all these topics to answer these questions. Okay. Then another one is define new attachment, enumerate various methods to achieve new attachment, and describe about the graft associated new attachment methods. So like that questions had been asked. These are the different questions which had been, so one by one we'll discuss, but certain, for example, we'll first deal with these two questions. Okay. That is classify osseous defects and add a note on autograft and allograft in the treatment of osseous defects. Then the second question is define and classify osseous surgery and add a note on the various steps involved in resective osseous surgery. So for both of these questions, I think the introductory part can be the same. Okay. That is, you can give the introduction, definition of osseous defect, the type of defects for the second question also. Only thing is that in the first question, you need to elaborate the different defects. You have to write 1 or 2 or 3 sentences under each of the defects. Whereas in the second question, you just enumerate the defects, list out the defects, and then you move on to the osseous surgery. Okay. So like that. So I have given it as like this. So you will have to write an introduction, definition of osseous defects, then factors which causes the bone loss, radius of action of bacteria, and the rate of bone loss, because these are what factors that determine that causes this defects, right? And then the classification of defects. Then you can write each of the defect and write 1 or 2 sentences underneath, and then diagnosis of the defect and the treatment of these osseous defects, then getting into the surgical part. Okay. So coming on to the introduction. Okay. So that is, in the normal scenarios, the alveolar bone height would be at the level of CEJ almost. So this height is actually maintained by a physiologic equilibrium between what all things, bone formation by the osteoblast and bone resorption by osteoclast. And this is also dependent on various systemic and local factors that influences it. So this is the introduction and definition. The osseous defects are those defects which are formed as a result of destruction of alveolar bone due to periodontal diseases. Okay. And the factors, what are the different factors that causes this defects or bone destruction? Basically, it is because of the extension of inflammation from the gingival margin, and also trauma from occlusion or various systemic diseases like osteopenia, osteoporosis are all causes for this bone destruction. Okay. And regarding the radius of action, you know, for a, this resorptive factors, okay, mainly plaque and, the toxins, bacterial toxins. So are the resorptive factors. So they need to be present at a distance of 1.5 to 2.5 mm. Okay, for this, for these toxins to exert their action on the bone and cause the resorption. Okay, so beyond this 2.5 mm, there is no effect. Okay, so that is the radius of action in which this defects would occur. Okay, and the bone loss, if the rate is set for a patient with no oral hygiene on the facial surface, it is seemed to be 0.2 millimeter per year, and on the proximal surface, it is 0.3 millimeter per year. Okay, slightly more. And coming on to the classification of defects, this is given in Chanticleer already, so I think you all can get access to it. There are different types, like the vertical defects can be classified by Goldpan and Cohen in the year 1952 as one wall defect, two wall, three wall, and combined. You can draw a picture also. One wall is nothing hemiseptic, only one wall is remaining, right? Two wall is two walls remaining, three wall is three walls remaining. Okay, that is the vertical bone defect, three wall defect. And similarly, other classifications where Glickman classified bone defects as craters, hemiseptal defects, infrabony defects, bulbous bone, all those defects are being enlisted. You need to by heart. And Pritchard, he expanded this classification, adding on furcation involvement, ledges, exostosis, and tori to this further additionally. And how do you diagnose this osseous defects? Basically, by clinical examination, you can, but not through normal probing. Okay. But then you need to do something called as transgingival probing. What is transgingival probing? Just with the periodontal probe itself, you just pierce the gingiva to feel the bony contour. Okay. And so you do it under anesthesia only, like with a more force, like around 60 grams of force is needed. And then you hold the periodontal probe perpendicular and probe it, or you can also do it through the gingival sulcus. So you can do transgingival probing. Radiographs, they're not very reliable. They only give the level of the bone that is lost or that is present, but not the morphology of the bone defects and all that. So the most reliable method is the surgical exposure. Only by opening up the flap that you will be determining what type of defect and where do it exist. Okay. And now the patterns of bone destruction, you have to enlist these patterns and write, different, you have to give the descriptions like horizontal bone loss, vertical defects, osseous craters. You have to write one or two sentences which are relevant. For example, in case of horizontal bone loss, this is the most common pattern. And here, all the bone, like the facial bone, lingual, and the interproximal, all the bone are affected. And then it is at right angles to the long axis of the tooth. Whereas ledges, they are plateau-like bony margins, and this is caused by what? Resorption of thickened bony plates. Okay. And bulbous bony contour, this is mostly seen in the maxilla, and this is because of exostosis or buttressing bond formation as a result of adaptation to function. Okay. This bulbous bony contour. Then osseous craters. Osseous craters are something that is concavity seen in the interproximal region. And this is the most common type of defect that is seen. And that too, that is most commonly seen in the mandible. Okay. And the reasons for its high frequency is because of its location. That is interproximally only it is seen. No. So plaque accumulation is more in that region. And otherwise also it has a slight concavity in the interdental area, so which favors the plaque accumulation and further resorption. Then the vascular patterns of gingiva also, favors the extension of inflammation in this region. So that is osseous craters. Then something about reverse architecture, which is most commonly, what is reverse architecture? You can write that is, normally it is the interdental bone that is coronal to the radicular bone. So in reverse architecture, it is vice versa, where the interdental bone is apical to the radicular bone. So this is mostly seen in the maxilla. And then the furcation involvement. And in that, you have to add on the grades of furcation involvement, which is proposed by Glickman. I think you all know it. Okay. And furcation involvement has been asked as a short knot. So if it has been asked as a short knot, you have to write in the classification, you have to write both the horizontal classification as well as the vertical component. Okay. And coming on to the vertical bone defect. So in vertical bone defect, which we have already seen, Goldman and Cohen has given this vertical bone defect classification. I think all of you would be knowing this one-wall defect, two-walled and three-wall defect and all that. This combined osseous defect would be something that is confusing. It is nothing but, the number of walls remaining in the apical area would be more than what is remaining in the coronal area. In such cases only, we call it as a combined defect. For example, in this figure, you can see in the coronal area, if you look at the mesial surface and the facial surface, bone loss has happened. But in the apical area, if you see, in the facial surface, the bone is intact. Only in the mesial surface, it is lost. So the bone remaining is more on the apical than on the coronal. So that's a combined osseous defect. Okay. And then next, so we have listed out the various defects, so bone loss patterns, and then the prevalence. So basically, bone defects are prevalent in the posterior segments because of thicker bone, that too the mandible. Okay, and the most common defect that is there is the interdental crater, and the most rarely occurring one is the hemisepta. That is one wall defect where only one wall will be remaining, and that will have a very poor prognosis also. And with regard to treatment of osseous defects, what all are the treatments? You have, osseous surgeries. In the osseous surgery itself, you have resective type, which is subtractive, and regenerative type, that is additive type of surgery. And the selection of which of this has to be taken is determined by the type of the defect. For example, in one wall defect, only one wall is remaining. So there is no scope of regeneration. Okay, so it should be contoured in such a way that no more plaque gets accumulated there. So it is resective is what is more commonly, preferred. Whereas in three-wall defect, all three walls are remaining, only one wall is lost. So regeneration has got a good scope there. So we'll proceed with regeneration. So it is basically based on the type of the defect. Then you have to give the definition of osseous. So until here, actually, for the first question, what we had noted, that is classify osseous defect and add on. So for the first question, I think all of what I have discussed now can be written in the essay question, and until resective and regenerative and selection of the treatment technique. It depends on the type of the defect. And then you can write maybe definition of regeneration and different techniques by which you attain regeneration, and then write a note on autograft and allograft, then conclude it. Then that will complete the essay. Whereas if for the second question, define and classify osseous surgery, add a note on various steps involved in resective osseous surgery. In that also, you can, you need, as I've already told you, you can write the introductory part as such. Only difference is that you need not write about each of these defects. You just enumerate, list out the defects, and then move on to the treatment aspect. Okay. And then write in detail about the resective osseous surgery. So that question is taken care of. So the resective or subtractive surgery in depth, it is what this is in resective surgery. What we are doing is we are aiming at producing a normal physiology. The definition and all you will need to by heart. Okay, so I'm not repeating it again because it will, anyways, you will not get, grasp it all together in the session. So you will have to sit and read and by heart it. I'll just explain to you what is what, so that when you read it, it will be easier for you. So in resective or subtractive surgery, what is happening is we are directing at forming a normal physiologic contour, okay, for the bone. And so indirectly that will result in a better physiologic contour for the gingiva also, because gingiva always follows a contour of the bone. Okay. So that is what we aim at, which, okay. Uh, but when we do that, in our attempt to produce that normal physiologic contour, we'll have to reduce some bone so that the bone level will be slightly apical to the level that was present before the time of surgery. Whereas in regenerative, we aim at restoring the lost bone in its form and function, okay, to the original level. Okay, but actually the ideal, in terms of ideal results, it is a regenerative surgery that aims at ideal results, but it is not predictable. We cannot say definitely you will get an ideal result. Whereas in resective surgery, it gives more predictable results in pocket elimination. Once this bone is reduced, the spikes in the bone, everything is reduced. Gingiva flows in a normal physiologic pattern there. So that it is be easier for plaque maintenance, and so periodontal breakdown and all that. So it is the resective that gives more predictable results, whereas regenerative aims at more ideal results, but with regeneration of lost bone, periodontal ligament, and fibers and everything. Okay. So regarding the classification of surgery, we have resective, regenerative, and also based on the thoroughness, we can classify them into definitive osseous surgery and compromised osseous surgery. Whereas definitive, it implies that, further reshaping wouldn't affect any overall, it wouldn't cause a change in the overall result. So we stop the surgery there. Okay, there is no much change that is going to be there with further reshaping of the bone. So it is definitive. Whereas in compromised osseous surgery, we do an osseous removal, but beyond which, if we do, it would be detrimental for the overall prognosis of the tooth. So we stop the surgery there. So that is what is compromised osseous surgery. Okay. So we do some amount of osseous recontouring, but you know, but after, if you proceed further, like it would be detrimental to the overall result. So we are stopping it. We are compromising it. So that is what is compromised. And then about resective osseous surgery, the major rationale, what is it? As I've already told you, it is to remove any discrepancies in the level and shape of the bone, so that it also, favors the normal physiologic contour of the gingiva. Okay. And you can write the indications and contraindications. Indications are all those areas, especially thick bony margins are there. Okay. And also where regenerative surgery doesn't have scope, like in one wall defects and all that. And exosources, tori, buttressing, bone formation, ledges, they all have thick and bony margins. No, so all these areas we have indicated for resective osseous surgery. Whereas it is contraindicated in areas where, first of all, where regeneration has got its scope, and secondly, this is contraindicated if further bone reduction, if it weakens the support system, then it is contraindicated. And also in aesthetic region, because once when we remove the bone, sometimes it will result in recession. So that is contraindicated. And regarding the armamentarium used for resective, you can use, it's a mixture of hand instruments and rotary instruments are used. Basically, hand instruments are preferred in areas where we do osteoectomy. That is, we remove the tooth supporting bone. Okay. But for osteoplasty, where we only, remove the bone that is not directly supporting the tooth, we can use rotary instruments like carbide, round burr, and diamond burrs and all that. Okay. So resective osseous surgery, it is done with two procedures mainly. Okay. Involving two procedures, that is osteoplasty, which I've already told you, where, the bone support, it is the reshaping the bone without removing the bone supporting the tooth. Okay. That is what is osteoplasty, where in osteoectomy, the bone directly supporting the tooth is being removed. And it is carried out in 4 stages. Vertical grooving, radicular blending, both of which are osteoplasty, where the tooth supporting bone is not removed. Okay, the bone other than the tooth supporting bone are removed. Where ectomy means removal, that is the bone that is directly supporting the tooth is being removed, which includes flattening of the interproximal bone and gradualization of the marginal bone. Okay. And what you can write as a note in your paper also, these all steps are not necessary in every case. Okay. But this is the order in which it is to be carried out, in most of the scenarios to obtain a normal physiologic contour. But in some scenarios, it might not be needed. Okay. If it is not that thick bony margin, maybe only the vertical grooving is needed. No radicular blending should be done. Okay. And under each step, you will have to write the most prominent ones. Like this is vertical grooving, where it is done. It is mainly done to reduce the thickness of alveolar housing, and it is done mainly with the round burr or carbide burrs, so rotary instruments. And this is a step, purely an osteoplasty step. Okay, this much is needed. And then with the radicular blending, it is a second step which follows the vertical grooving. So here what we do is we reduce the thickness of the bone over the radicular surface to produce a smooth blended surface so that good flap adaptation will be there. And then you have the flattening of interproximal bone. So this is all given in the textbook, and you can just write two or three sentences, which is very relevant under each of it. Okay. Maybe why it is done, and then also like with what instrument it is being done, and whether it is osteoplasty or osteoectomy procedure. For example, gradualization of marginal bone. Okay, that is a step that is done to remove the bony spicules that are present, that may be present in the bony margins. Okay, because it is otherwise called as widow's peaks. If it is not removed, the gingiva, once after healing takes place, they will follow that contour, which will result in plaque accumulation and further periodontal breakdown, pocket formation. Okay. So then about the conclusion with multitude. So with that, we have covered the steps of resective osseous surgery. So when you come to the conclusion, with multitude of advantages, this serves to be an important technique in the armamentarium necessary to provide a why this is being done. That is what is explained here. Okay. To give a patient a maintainable periodontium. Okay. Which follows a normal physiologic contour. Maybe at a level slightly below that which was present at the time of surgery, but a normal physiologic contour. That is what is attained in a resective osseous surgery. And finally, now coming on to new attachment procedures and, the various methods to attain it. And bone graft and non-bone graft associated procedures. So these are the headings under which this is being described. So, with regard to new attachment procedure, actually, when we speak about periodontal therapy, the ideal periodontal therapy is said to be, the objective is not only to control the periodontal disease, but also regeneration of the lost tissues in the periodontium. Okay, that is what the main aim of periodontal therapy is ideally. Okay, but a technique that would bring an ideal result is always in search. Okay, so coming on to definition, new attachment. Okay, it is nothing but embedding of the new periodontal ligament fibers onto the new cementum and the attachment of gingival epithelium to the tooth surface previously denuded by the disease. So here, everything is new, right? The new periodontal ligaments have formed and they got embedded into the new cementum. And also after the therapy. And also what happened, this gingival epithelium has gained its attachment over the tooth surface, which is previously denuded by the disease. This figure, this gives an example. This was a pocket. This is a figure which shows a pocket. And then the pocket has been removed. Maybe lining has been removed. And then after healing, you can see there is epithelial attachment regained, periodontal fibers are formed, the bone lost is also regenerated. So this is a case of new attachment. Okay. So when you speak about new attachment, there are certain terminologies that you need to know and has to write about. There is something called as regeneration. There is something called as repair. There is something called as epithelial adaptation and reconstruction. Okay, what are each of its difference you need to know. Okay, so regeneration is nothing but it is a natural renewal of the structure by the growth and differentiation of new cells and the intercellular substances. Okay. And this will result in what? This new cells and substances, when formed by growth and differentiation, this will result in gain in attachment and bone regeneration. So this is where new attachment takes place. Okay. This is actually new attachment is something that takes place when regeneration happens. Whereas sometimes after a periodontal therapy, it is not always that regeneration, it's not a must that regeneration happens. That is why we say predictability is poor for regeneration. Even though it aims to give an ideal result, we cannot say that always it gives off that ideal result. Sometimes healing by repair happens. It simply refers to restoration of continuity of the deceased marginal gingiva. Okay. There is a normal gingival sulcus that has been re-established at the same level on the root surface as the pre-existing periodontal pocket. That superficial healing has taken place, but there is no formation of new PDL or no formation of new cementum, or even the bone, the alveolar bone that was previously lost is also not regenerated here, but only that epithelial attachment has been regained there. So that is the superficial, the restoration of continuity has happened here. So that is when we call it as repair. Okay. So this epithelial adaptation is something that happens in repair, where you see this differs from new attachment in that, in epithelial adaptation, only the epithelium, it gets adapted to the tooth surface. There is no direct attachment, but it gets adapted to the tooth surface by the close apposition. So, and there is no, see here, there is no gain in fibers here. Okay. This is what is called as long junctional epithelial formation. So healing by repair, it actually shows epithelial adaptation or long junctional epithelial formation. Okay. And reconstruction is also same as the periodontal regeneration, where everything is being reconstructed. That is the periodontal ligament fibers newly formed, level of alveolar bone is also, it's a process by which this regeneration of cells and fibers takes place and loose periodontal tissues are reconstructed. Okay. So in this picture is very relevant in terms of this. Here you see, I've already told you, the C is what is new attachment is or reconstruction is. Okay. Where all the tissues are being reconstructed and the gain in epithelial attachment and bone level and everything is being obtained here. But in D, it is repair, healing by repair, where periodontal ligament fibers are not newly formed and healing is by long junctional epithelial formation also. Okay. So ideal periodontal regeneration, the ideal outcome is new attachment. Okay. But what so for why this long junctional epithelial formation has seemed to happen, it is because this epithelial cells has got a high proliferative rate and they migrate very fast, like 0.5 to 1 mm per day. So the reason for this long junctional epithelial formation was assumed that they migrate at a faster rate than the PDL cells so they don't give that time and space for the PDL cells to come form their attachment. Okay, so this concept was proposed by Melcher, and he said that it is based on the type of the cell that repopulates the area after the periodontal surgery that determines the nature of attachment, whether it is healing by repair or whether it is, new attachment that is formed. So, for example, there are chances that epithelial cells can repopulate. There are chances that connective tissue can repopulate. There are chances that alveolar bone can repopulate. And also there are chances that the periodontal ligament fibers can repopulate. Okay. So each of which will give different types of attachment. Okay. For example, if the epithelial cells repopulate, it is long junctional epithelial formation. Where is it? Yeah, here. And if it is the bone that repopulates first, it will be resulting in, ankylosis, direct attachment of bone with the tooth, no? And if it is, the PDL cells that is repopulating, it will result in PDL fiber embedding, and also it will cause the bones to reform. So it is new attachment. Okay. So it is based on that. So, and it pointed out that it should be ideally the PDL cells are the ones that has to be repopulate the previously denuded surface after periodontal surgery. Okay, to bring about the ideal outcome for periodontal regeneration. Because it has got this both synthetic cells, all the synthetic cells, bone forming cells, cementum forming cells, and fiber forming cells also. Okay, then that is what is Melcher's concept. I think it is clear. And then evaluation, how do you evaluate if a new attachment is obtained or not? You can, there are different methods, but histologic method and surgical is the most reliable one, but it is not practically possible. But you can just enlist the methods, okay, clinical methods, radiographic methods, by surgical re-entry, and histologic methods. And then about the techniques of regeneration. Okay, when you speak about the techniques, you have known bone graft associated technique, where we don't use any bone graft, but certain other procedures we'll do to obtain regeneration. And also there will be graft associated procedures, materials and procedures, and then combined, a combination of both of this. All of this together, attend where it is needed, can be used to attain this regeneration or new attachment. Okay. So it includes what known bone graft includes: removal of junctional epithelium or pocket epithelium. Okay, pocket is being removed. Then prevent the epithelial migration after the therapy into that space. So for that, you need to stabilize the clot, protect the wound, and stabilize the space there, create the space there for the ideal cells to come and repopulate the area. So that could be accomplished with different methods, and GTR is one of them. Okay, then the fourth one is GTR. And then root biomodification is an adjunct that is being performed. And this is a short knot also. Okay. And then this much, until this much, it comes into known bone graft associated techniques. Okay. So there was a question like define new attachment procedure and then enumerate in detail the known bone graft associated. So you will have to write up to this and then in detail about these 5 procedures. Okay. And from the 6th procedure onwards, it is graft associated. There is selection of, you have to write about the various bone grafts that are there and the different properties of the bone graft, and also selection of proper bone graft, the criteria, then biological mediators, growth factors, and combination. That all come under generally when we speak about the new attachment procedures. But specifically, if known bone graft associated is asked, you will have to enumerate a detail about this up to this 5, number 5. Okay. So non-bone graft associated procedures, where it is indicated. Okay. In, 3-wall defects basically, and also in cases, in acute bone loss happens, like in abscesses and all that, you can use this non-bone graft because complete removal of the etiological factor and providing an ideal environment for the cells to repopulate itself would regenerate the lost tissues there. But, there will not be a need of graft to be placed there. And so the techniques I have already described it. I mean, I've told you that. And in that, you have different techniques. Like, for example, if you need to remove the pocket epithelium, you can do a gingivectomy, a curettage. You can do, chemical agents, which is not currently in use, but you have to write when it is exam, and ultrasonic instruments and ultrasonic methods. But most reliable is the surgical method, flap surgeries and excisional new attachment procedure, where it is just curettage, but done with a blade. Okay, that is what is ANUG. So these are all given in the textbook, but you will have to write one sentences underneath also. Okay. And then next is the prevention of epithelial migration after therapy and wound stabilization and all that. Actually, GTR provides these 2 and 3, actually satisfies the 2 and 3. But before the GTR was introduced, actually there were 2 methods that was followed for this prevention of this epithelial migration. Okay. So one was like we place the flap coronally advanced so that the distance between the flap edge and the defect space is increased. So that assuming that long it will take the cells to migrate, no? So by that time, the favorable cells will repopulate the area. Similarly, another one is removing the interdental papilla in that region and then keeping a graft over there. So the graft simply delays the proliferating epithelium from reaching the gingival surface. So then about this wound protection, clot stabilization and all. Actually, this was assumed to be needed because the fibrin clot, they seem to act as a mediator until the cells, favorable cells, that is the PDL cells, would repopulate the area and prevent the epithelial cells to come and, migrate over the surface. Okay. And for GTR, I have detailed, I'll be explaining it in the subsequent session because there is a question with an essay question that has been asked with regard to GTR. So with that, I'll explain. And with root biomodification, you all should know how to write a short note on root biomodification. This is one of the new attachment technique And this is what is being done. It is actually, in relation to the pocket, the cementum would be altered. So there will be, pathogens, toxins, everything. So in order to detoxify, decontaminate, and demineralize the root surface, that we use this. Okay, and what are the agents that is being used? So in a way, by root biomodification, what we are doing is we are making the environment on the cementum or the tooth surface ideal for the new attachment to take place. Okay. So that much is what is there in known bone graft. And in bone graft associated, you will have to write about autograft, allograft, xenograft, isograft, and alloplast. Okay. And you shouldn't get confused between known bone graft new attachment techniques, and there is something called as known bone graft material. When it is known bone graft material, it is alloplast, which are synthetic materials, which are not, really bone, but, made synthetically, almost, equalizing the properties of bone, like bioactive glass, calcium phosphate. The reason why I'm telling this was asked as a short note, known bone graft material. Okay. So then you have to write about this bioactive glass and calcium phosphate biomaterials and all of this. Okay. And this table is also, I'll try to share with you. This is very self-explainable table only. And here the short notes can be asked from autograft, allograft, and alloplast. Okay, these three can be asked as a short note. Okay. And these are the properties related to bone graft: osteogenic, osteoinductive, and osteoconductive. Osteogenic are nothing but the bone, the graft itself has cells which can produce new bone cells. Okay. New bone can be produced from the graft that is placed there. While osteoinductive grafts are those which has a property of stimulating the adjacent cells to produce the bone. They themselves don't produce the bone. Okay. And osteoconductive, they just remain there in the defect. Okay. They provide that space and time for the cells to repopulate the area. Okay. They actually act as a supporting base or a scaffold only. They don't have osteogenic or osteoinductive property. They don't form cells on their own. They don't induce cell formation also. But the natural process, no, to take place, that requires some time. So until then, they remains there, and then gradually they resorbs, like as and when new bone deposition happens. So out of which, autograft is a gold standard because it has all the three properties. Whereas in allograft, and all the rest, only has osteoconductive property, except for this allograft, demineralized freeze-dried allograft. So these tables and all, I'll try to share so that you can easily remember it. Okay. Then when you are asked about bone grafts, you have to write the ideal requisites, ideal requirements like biocompatibility and feasibility, predictability, patient acceptance, all that. And this is, I've told you, autogenous grafts have been used, have been asked, or allograft have been asked, alloplast, known bone graft materials also have been asked. So you have to write the definition. So they are all can be asked as a short note. So you can write definition for each of it, from where it is procured, and the examples you can give, and one or two sentences under each of this example. That is how it would complete the answer. Okay. Now the last question which I'll be discussing, and I'll also be sharing some other important short notes which are being frequently asked, some unexpected questions also. So now we are directly moving on to GTR. So already we have explained a major portion of GTR. So even when your GTR is asked, you have to write until the Melchor's concept. Okay, the terminologies: new attachment, regeneration, reconstruction, Melchor's. Until Melchor's concept, it is the same. And from Melchor's concept, it is completely, regarding the GTR alone. That is guided tissue regeneration, where we speak about the membranes and all that. Okay, so until Melchor's concept, it is the same. And then you have to write about GTR rationale, why this is being done, to prevent the epithelial cells migrating into the defect, and for what all things, space creation, wound protection, and all those things, fluid stabilization and all that. And also for providing, selective guidance for the cells, PDL cells, to repopulate the area, right? And then you have the different membranes which are used for the purpose. The properties of membranes should be enlisted. And then the different membranes. First generation, which are non-resorbable. Second generation, which are resorbable. And third generation are resorbable with growth factors. Okay. And you need to write the examples under each of it. And finally, the steps. That is, a full thickness flap is being raised and then debride the area. Then trim the membrane to the site of the defect. And so that at least 2 to 3 mm, should cover the defect area. And beyond the defect, it should be present. Then the flap is sutured back, completely covering the membrane. So then you can write the indications which is being indicated, like in intra-bony defects and also in greater furcation, and in areas where bit of attached gingiva is adequate, and where the tooth is not mobile, and also in case of periodontal lapses, like conditions where you are intending to regenerate, all that. And this is contraindication where grade 3, grade 4 furcation areas, and in horizontal bone loss, ridge augmentation and all, it is not indicated. Okay, it is only used in areas where you can contain the graft. Okay, and you can suture it. And this is healing after GTR. This is all taken from SATO, so you will not be getting access to it directly. If possible, this can be written. Otherwise, you can omit. It's not a mandatory thing that this is to be there. Okay. So next is regarding the complication. The major complication with GTR is, this membrane exposure and infection. Okay. Other complications are pain and purulence and exudation and swelling and tissue perforation and all. Okay. Then conclusion. The principle of GTR, it lies in the establishment of cells. Okay. Of the PDL in this previously denuded root surface that has been periodontally treated. So just you can write whatever that is being read. Whatever you feel it is ideal. But the use of GTR membranes can lead to significant periodontal regeneration, formation of cementum with new fiber attachment. Okay, so that's it. And other essays, if particularly, GCF is an important essay question, methods of collection. Okay. And also questions always, don't skip GCF because you can expect one short note at least from GCF, like either in the form of method of collection or composition and function. Okay. Or the clinical significance of GCF, these three things. And then plaque, define and classify plaque. That is one another major question, and different steps of plaque formation, and plaque hypothesis is an important short note. Okay. And with calculus also, define and classify calculus, theories of calculus formation and mode of attachment of calculus is important. And similarly, gingival enlargement, drug-induced gingival enlargement is very, very important. And also another important question is the prognosis. Okay, that is not very frequently asked. I think only once it's been asked, but it is not an area which everybody would read, so don't skip it. That is define and classify prognosis and describe the factors affecting it. And then you have various short notes. So from the gingiva, the short notes that can be asked are like attached gingiva, junctional epithelium, gingival fibers, dentogingival unit. Then from the cementum, the classification and hypercementosis is a very frequently asked question. Stages of gingivitis is yet another very, very important area. Then chronic periodontitis itself has been asked as a short note many times, and otherwise the models and radiographic features are also asked. Then, yeah, and then regarding the trauma from occlusion, the classification is very important. And these are the different important section from plaque control and instruments. Okay. So there is a brushing technique, then chlorhexidine, disclosing agents. They are very important. And instrument part, the Gracie cure. Okay. And I've already told you acute gingival infection, the whole chapter as such is very important. And furcation also, I told you while I was describing the osseous defects. And periorestorative phase, that is towards the end of the textbooks and all. So sometimes chances are that you will skip it. Read about biologic width and crown lengthening procedure. With implants, peri-implantitis and implant mucositis. That is the most frequently asked question from implants. And these are some random topics which might come. Okay, some unexpected areas like loops in microsurgery, then periodontal packs, pathologic migration, LDD, then supportive periodontal therapy. So like this. So you can, maybe I can share these questions along with you. If you need it, please approach us. So I hope the session was useful in one way or the other. Okay, if you have any doubts, you can, already time is too much. So if you have any doubts, you can quickly ask in, or you can just message in the group. Okay. So I think I'll stop the session.